I'll just run through very quickly the agenda. We have actually invited 6 of our previous fellows to speak, 3 clinical and 3 AHPs, and we've chosen these because of their work that they've been doing and the fact that they have worked within 3 of our priority areas, that's early diagnosis, reducing variation, and personalized care. And I'll be introducing each of them in turn in a few minutes, and we'll be having some questions. If, in fact, we haven't had time to cover the questions in their presentations, we'll be covering those in a panel discussion, which we'll be having at the end of the afternoon. We'll be having a break between the presentations, and Claire Shaw, who's a consultant dietitian at the Royal Marsden, will be doing a review of her experience in supporting AHPs in research. As you will hear, it's crucial to for our programme that we support both clinical and AHPs in this endeavour. What we'll do now is have a look at the background to the programme, and it's my pleasure to introduce Michelle Chen, who is the Research and Innovation Lead at RM Partners. Michelle?
Hi, good afternoon, everyone. I don't know if you can see me. There you go. There's my camera. Afternoon, everyone. So the research fellowship started back in 2015, back when it was the kind of London Cancer Alliance, as an integrated cancer system that spanned West and Southeast London. It was an idea that generated out of the established research board, which covered all of London, to kind of set up the research priorities across the network and the stakeholders at the current time. In the first year, with support through the BRCs at Imperial and the Mars and ICR, we appointed 4 fellows, 2 medical and 2 allied health professionals in areas of early diagnosis, reducing variation, cancer in older people, and managing treatment effects. By 2016, the Cancer Vanguards had taken shape, which were the kind of eventual blueprints for what cancer alliances were to become. And it was an opportunity for us to then engage with our colleagues over at North Central and North East patch of London, which was hosted by UCLH Cancer Collaborative at the time. We then set out a Pan-London Research Consortium, which set out the research priorities for that award, for the awarding of that year and kind of going forward. And every year we've been able to kind of continue supporting the annual research fellowship program with support from the now 4 cancer alliances and the 2 West London BRCs. As of last year, a total of 1.8 million has been invested into the program to fund 33 research fellows, 17 of which are medical and 16 who have nursing or AHP backgrounds. This is our first inaugural fellowship showcase, and we're really excited to hear from our fellows how the 12-month research fellowships have helped shape their careers and the new collaborations that have been built across London. Next slide, please, Anna. So there's a wealth of cancer research expertise in London, and this map here only shows a small proportion of our key partners. In order to kind of strengthen that London research network, we set out certain requirements to fund projects that are kind of collaborative across organizations to deliver on alliance-led research, which all have a common goal of achieving the long-term plan, which is set out by NHS England. Next slide, please. So the aims of the research fellowships are as follows: supporting patient-based clinical relevant research. And each year, the Pan-London Research Steering Group which has membership from each of the alliances and the BRCs across London, discuss what the specific priority areas should be. And previous work stream examples have been kind of focusing on areas of early diagnosis, addressing cancer inequalities, and aspects of personalized care. The research fellowships also look to fund high quality research of unmet need, and building research capacity in the alliance. And this is really important to us, like Stan said earlier, by creating that kind of opportunity for individuals with kind of nursing and allied health professional, that specific kind of cancer workforce to help them take the first steps into developing a cancer research career. And we're really thrilled to have supported as many nurses, HPs, and GPs as we have with medical and clinical oncologists and surgeons. And now that they've got established links and networks into cancer alliances and across London. And lastly, kind of building the London-wide research collaborations, which will only kind of strengthen future funding grants and benefits towards the London population. Next slide, Anna. So the selection process of the fellowships is a two-stage approach. An initial call for projects is made and shared widely through our organizations, the BRCs and our stakeholders, and there's a shortlisting criteria against the project and the supervisor that the selection committee scores against to produce a shortlist. The selection committee is made up of scientific advisors, academic clinicians, representative of the organizations across London, and the workstream priorities and PPI members. The shortlisted projects are then advertised for interested candidates who are then asked to contact the supervisor to write up a joint fellowship application. The proposal again is reviewed by the selection committee, and fellows are invited for an interview. And depending on the number of awards available that funding year, the number of interviews held and projects advertised adjusts accordingly. Once the research projects are awarded and funded, meetings are put in place with the Fellow and RM Partners Directorate to monitor progress. Sorry, that's the next slide, Anna. Which includes kind of updates, progress against milestones, and supports against any kind of barriers or issues. Support is also provided through the fellowship on advice on funding or research governance, such as NIHR, HRA, ethics, and in terms of the outputs and kind of sharing those and how we disseminate, a lot of the publications are often linked to our RM Partners website and disseminated on Twitter, and often updates on research projects and findings are presented to kind of tumor-specific pathway groups at RM Partners. So we're really excited to be able to launch a program again this year, and with that, I'll hand back over to Stan.
Thanks. Thanks very much, Michelle. One thing I should say, and I didn't say at the beginning, and if we look at the people who've helped put this in place, I just wanted to mention one or two names and say thank you to them. They're going to be taking part in the panel discussion, which we'll have at the end, and that's Arnie Purushottam, Mick Peake, and Tom Round. So thanks in advance to you guys for helping to make this happen. I think I also did say that we are going to have a recording of this webinar that will be made available after the session. Good. Well, without further ado, let's get on and listen to the presentations. The first is by Dr. Tim Hoogenboom. Tim is a medical sonographer and clinical data scientist. He's been working in the important area of potential early diagnosis of liver cancer, which I'm sure will be an increasing message for our alliances in London as time goes on. So, Tim, welcome. Multiparametric ultrasound for the assessment and clinical management of NAFLD and HCC. Tim?
Thank you. Yes, actually, we can move right on to the next slide already after that introduction. So yeah, I wanted to briefly touch on, I guess, my career and how I sort of moved through this and where I was kind of helped through the funding I received. So initially, I was working in the Netherlands as an allied health professional, as a sonographer primarily in Amsterdam, and I moved to London to do a master's in medical research, basically because I had this interest in trying to just understand why we were sort of making certain decisions within healthcare. Following my master's, I became a clinical trial monitor for a short time while applying for funding to do my research. So then I essentially I got my funding and I started working as a clinical researcher. Went back to being an allied health professional during the pandemic, and now I'm working as a clinical data scientist within healthcare research still. Next slide, please. So my RM Partners funded project, so essentially it was a proof of concept study, and we wanted to really understand if a combination of measurements would be able to determine risk of hepatic carcinogenesis in a fatty liver disease population. So we knew essentially that in this cohort of fatty liver patients, we were seeing a lot more liver cancer appear, and we were trying to understand why it was happening and how we could essentially identify these patients early on. Particularly because fatty liver disease affects a huge proportion of the population, so this could potentially be a big problem. So a lot of these patients actually get an ultrasound as part of various follow-ups or scans requested by GPs, and we thought maybe if we can just get more information out of these ultrasound scans, that would be a really good place to start in terms of screening. So we looked at various measurements that we could essentially extract at that point. Next slide, please. So I won't go too deep into this, but this is kind of the sort of pathogenesis of both fatty liver disease progression, which is very closely linked to liver cancer development. Essentially, you go into this inflammatory state, and that results in oxidative stress, and liver cancer is more likely to develop in such livers. And one of the things we can see is in the image provided here is rat livers that have been scanned with a synchrotron. And essentially across different stages of disease severity, we can see that there's a lot more blood vessels appearing in different configurations. So the idea was, can we actually just visualize this on ultrasound, and would that help us identify these cancer patients? Next slide, please. So after 1 year of funding, which is what the ARM partners provided, we essentially had started and recruited 60 patients and volunteers into our clinical trial. We created a database of thousands of images. It was actually quite massive, of the liver, of liver tumors, etc. We collected serum and plasma samples from all of these participants, and we also obtained a lot of clinical information around sort of biopsy results that they may have had, or FibroScan results, etc. And we started working on initial image filtering and motion correction, which was quite rudimentary at the time, but we essentially concluded that it was possible to kind of visualize these very small vascular structures within the liver, and to do so in a fatty liver disease cohort, which I'm not sure how many of you are familiar with imaging of fatty liver disease, but it can actually be quite challenging. Not a lot of sound travels very deep in those tissues. So we essentially proved that it was possible to see both the liver and tumors quite reliably. And we also noticed that there was a huge variability in liver stiffness measurements and attenuation in this population. And that was obviously quite concerning, because that meant that we couldn't really rely on that as a metric for what we were trying to look at, which was disease severity and risk of cancer. Next slide, please. So based on the 1 year funding, I was actually able to use the data to apply for further funding, which helped fund my PhD. We also were then able to scan additional patients, and we were able to scan them at the same time as their hepatology appointment. So this meant that actually for the people who participated in my research, that was kind of a huge benefit, because it meant that they didn't have to keep coming into hospitals for various appointments, when it was kind of all combined to one single moment. We put everything together in a database called Malus, which is still active, and many MSc and BSc students have completed their sort of research projects using data from this database. So this kind of keeps going in terms of outputs being produced. I'm quite proud of that still being there. Yeah, we can move on to the next slide. We also had some publications, mainly around sort of some of the machine learning work that I'll be discussing a bit further later on, as well as presentations at BEMUS, which is sort of the main ultrasound conference in the UK. Next slide, please. What did I actually do? Right, so in terms of the actual project and how it ran, so because I feel like it might be a bit conceptual up to this point, but essentially I found these patients, healthy volunteers, and people with sort of varying degrees of liver disease. I subjected them to ultrasound scanning with both micro bubble contrast agents and something called super microvascular imaging, which is essentially Doppler imaging. And that allowed us to visualize these very small blood vessels. And then basically developed a method of video analysis, which included both image processing and motion correction. And then I extracted various features that describe these vascular structures. And then I used supervised machine learning to try and understand what these features could mean, and how they could help us differentiate between the different cohorts of patients. And then I correlated those metrics with other sort of known metrics for liver disease severity, as well as serum protein levels for certain proteins that were associated with angiogenesis. Next slide, please. This is the scanning protocol that I used to collect the data. We won't really have to stick too long into this, but essentially I developed a protocol that allowed me to kind of collect as much information as possible from this cohort of patients. Next slide, please. this is kind of the end result of what we're looking at. So the first image is a region of interest with showing these sort of microvascular structures within the liver, which we then binarize these images, we identify vascular structures, and then we do this feature extraction process following something called skeletonization. So you essentially reduce everything to a skeleton. Next slide, please. And this is what it looks like for a liver tumor. And I think the main thing to kind of focus on is that we can very clearly see that the blood vessels here are aberrant. So they're curving and not really following a pattern that we would describe as healthy. Next slide, please. And then essentially I spent a lot of time developing various machine learning models to try and make sense of this data. And this is the image that I chose to display because I think it's most applicable to what we're talking about. Essentially, what I did for this particular experiment was I looked at the liver parenchyma of both cancer patients and non-cancer patients with chronic liver disease. And I tried to see if I could differentiate between the two of them. So this means that the machine learning model has seen vascular structures within the liver of both these cancer patients and non-cancer patients, but it hasn't seen any tumors itself. And we could actually differentiate these livers based on the vascular parenchyma alone, vascular structures within the parenchyma alone, which means that there's something in the liver parenchyma of cancer patients that is different or allows us to differentiate between non-cancer patients. And I would argue that this is, these more aberrant vessels caused by this sort of more oxidative stress that's, been subjected to this liver. Next slide, please. So I think kind of taking a bit more of an overview, stepping back and looking at the outcomes of my project and what this kind of means for clinical practice, I think that although it's incredibly interesting to look at these vascular structures and potentially very useful for differentiating between patients, I think realistically it's probably quite complex and expensive to use in a screening setting, and therefore it might be more useful in a drug development or treatment development kind of setting. But I do think that one of the main lessons is that this oxidative stress component, which is very independent of other measures of liver disease severity, like liver stiffness measurements or looking at fibrosis, that is actually a very important feature of disease progression, and it is directly linked to the risk of hepatocarcinogenesis. So really, we should be looking at this, I think, a bit more closely, either by looking at certain proteins that we can find in serum, or we can look at maybe metabolomics, which is something that I started working on before leaving Imperial. But yeah, I think that's kind of the main takeaway from my end is, there's definitely something about this oxidative stress that we really should be looking at when examining these livers, and we're not very good at doing that at the moment, but it's certainly possible clinically. I think that's it for me.
Thank you very much, Tim. That's really interesting. I don't know whether we have any questions that have come through the chat line. Just one thing from me. I guess it sounds as if moving on to look at oxidative stress, that component is going to need some kind of serum measurements. I know that there are potential ctDNA markers that are being looked at. So it sounds from what you said as if clues towards screening for liver cancer in those at risk is going to involve some element of testing of serum from patients at risk. Would that be reasonable?
So yeah, that would be reasonable. I do know that there is also a urine test actually that works on metabolomics that's being developed that's actually able to look at this oxidative stress component as well. And certainly, obviously, that would be very useful because urine is much easier to kind of acquire. But yeah.
I think Mick, is that Mick Peake has got a question?
Yes, it is. I don't know what the problem is, but I don't seem to have a chat function on my screen with a version of Teams, so I apologise. I was just wondering whether ultrasound for FLD, for fatty liver disease, was being thought of as a screening measure on its own, not necessarily screening, but a risk of stratification tool. and whether, if it is, whether there's more that could be done with machine learning to make that more predictive.
Yeah, so there has actually been quite a bit of research looking at sort of using ultrasound texture analysis to try and make sense of these things. Historically, that hasn't really been very successful. I do have to say that ultrasound technology has improved so much. It goes so fast. So, for example, some of the images that I was producing with contrast-enhanced microbubbles for my study, I certainly believe that it would be possible to create those images without using contrast agent at this point, just because the technology has improved. And I think if that happens, then certainly you could actually apply some of the methodology that I did in a much more simple, non-invasive way during an ultrasound screening tool. And realistically, I think that's a very reasonable approach, because really what you're trying to do is visualize some blood vessels and get some kind of measure for how aberrant they are, and that should be possible depending on how sort of high your image quality is. The problem is that fatty liver disease obviously occurs most often in obese patients.
Yes.
And it's quite challenging to get sufficient signal from these patients. Yeah. So a lot of the images that I produced, they were produced in Japan already without using contrast agent, but they were produced in a cohort of very skinny Japanese men with hepatitis B, which is not really applicable to my cohort.
No.
Okay, we've got time for one more question, I think, and I think, is it Arnie? I can't tell from the chat line, but
Hi, Stan. Thank you, Tim. Thank you for that.
Quick question.
If you institute an obesity management program in patients in whom you see a fatty liver, do you actually reverse the changes of the fatty liver if they reduce their obesity, and does that change their risk for the development of HCC?
So I wouldn't know if I have a fully evidence-based answer to that. We know that in animal models, the vascular structure of the liver actually does revert to normal if you resolve obesity. So that would imply that, yeah, it does improve and it does reduce the risk of liver cancer development for sure. And indeed, I actually think, when we're talking about screening in fatty liver disease, potentially we really need to do the kind of health economics analysis of potentially it would be more cost beneficial to support patients in losing weight rather than screening everyone, because we might not pick up everyone at an early stage, but we could actually reduce the number of people that get cancer, which is, I think, maybe a more appropriate goal in that sense. So the answer is, I suspect yes. There's some evidence in support of this, but I don't think there's been much published in humans. Yeah.
Thank you. Thank you.
Okay, Tim, thanks a lot. If there are any other questions, we can pick them up in the panel discussion at the end. I hope you stay around for that, Tim. That's very good. Thank you very much indeed. Let's move on now to the second presentation. We're now turning to a trainee surgeon, Theo Giorgio Delille. Theo has been working for some time on aspects of the FIT test, fecal immunochemical test. Here's his title: Implementation of the FIT test in the diagnostic pathway for colorectal cancer. And he's going to explain the work he's been doing and how that's led him on to where he is now. So, Theo, can you see us?
Yes, I can see you, can hear you. Thank you.
So
Thank you very much.
Off. On you go.
So, so my name's Theo Giorgio Delille. I'm a surgical registrar of South West London, and I'm going to discuss my thesis today, which is, as said, implementation of the fecal immunochemical test in the diagnostic pathway for colorectal cancer, mixed method study. So today I'll be discussing the project and my experience of the fellowship. So first, I'll give an overview of the project and how I got involved. I'll discuss the application process and, importantly, what I learned during the fellowship. I'll discuss how the fellowship has helped me in my career, and finally, recommendations for other surgeons wanting to do research. Next slide, please. So my fellowship project is based on a stool test called the FIT test, or fecal immunochemical test. FIT is non-invasive quantitative immunoassay, which detects hemoglobin in feces. And FIT is used in bowel cancer screening programs worldwide. And in England, FIT was introduced into the National Bowel Cancer Screening Program, replacing the fecal occult blood test in 2019. The NICE-FIT study, a multi-centre diagnostic study set up in collaboration with RM Partners and Croydon Hospital, found that in addition to screening, FIT could be used to triage patients with suspected colorectal cancer symptoms for colonoscopy if the fecal hemoglobin was above 10, as the negative predictive value for colorectal cancer at that threshold was 99.6%. Next slide, please. So why does FIT in symptomatic patients matter? Well, there's a need for symptomatic FIT referral pathway to triage two-week referrals from an economic perspective, as urgent referrals have increased by over 90% over the last 5 years. And approximately 60% of these patients undergo colonoscopy, which is invasive and does carry with it a small risk of complications. This puts pressure on NHS endoscopy capacity, which can lead to delays in colorectal cancer diagnosis and treatment. And in addition, COVID-19 has increased the endoscopy backlog. So if FIT could be used by symptomatic patients to help rule out bowel cancer through a low fecal hemoglobin, then patients could be reassured and avoid an uncomfortable investigation and endoscopy capacity maximised. Understanding patient perception, experience and acceptability of using FIT to guide investigations in the context of having colorectal symptoms is crucial. And research on patient experience of home fecal tests has tended to focus on the fecal cord blood test, and the small number of FIT have focused on their use in screening mainly. And so there's a lack of patient-orientated research in symptomatic patients, and they need to better understand variation towards FIT when used to guide referral. The NICE-FIT study showed that FIT could categorise colorectal cancer risk for patients by fecal hemoglobin, but may not be sufficiently predictive on its own. But the NICE-FIT study also recorded other patient parameters, including blood markers, demographics and symptoms, which created the possibility for developing a more personalised risk categorisation based on a combination of these other parameters alongside the fecal hemoglobin. So next slide. So my research hypotheses were therefore that understanding patient acceptability and variation in perception of the FIT test could improve the design of the FIT symptomatic pathway. And also there's a colorectal cancer risk tool involving individual patient factors in addition to fecal hemoglobin could be used to benefit the FIT symptomatic pathway. So next slide, please. So I'm now going to present one aspect of my project, which was a patient survey on the FIT undertaken. A literature review was used to develop a patient FIT questionnaire, and 4 questionnaire themes were identified to contribute to the research question. So that's the feasibility of FIT for patients, patients' feeling of fecal aversion related to FIT, their intention to use FIT again in the future, and their knowledge related to the FIT test. The questionnaire was disseminated to participating NHS hospitals across England as part of the NICE-FIT study, and 25 sites recruited patients between December and July 2018 to 19. Eligible patients were those referred from primary care with suspected colorectal cancer symptoms under the 2-week wait pathway and triage for colonoscopy. Next slide, please. So here we can see the results. So questionnaire packs were sent to 3,760 patients within the NICE-FIT study, and 31% were returned. Of these, 91% of questionnaires were answered, and almost all patients who answered the questionnaire also returned the FIT test. If you click again. So the mean age was 65 years, if you just click again on the slide. 56% of patients were female, 88% from white ethnicity, 95% had a preferred language of English, and 72% had previously used some type of stool test. If we look at the feasibility of FIT, over 90% of patients found that FIT was practical, agreeing it was straightforward to collect the fecal sample, and the device was easy to open and close, and the instructions themselves were easy. 78% agreed they prefer FIT to colonoscopy, and 90.5% would prefer to return FIT through the post. If you now look at FIT and fecal aversion, if you just click again, 76% of patients disagreed that FIT was unhygienic, and 77% disagreed it was hard to overcome disgust related to stools. 79% disagreed it was difficult to overcome embarrassment related to FIT. And finally, we found that 95.8% of patients would use the test again. Next slide, please. So differences in FIT perception were found between patient groups. Patients who responded to the questionnaire and used FIT that was able to be analysed and produce a fecal hemoglobin result were 4 times more likely to find it straightforward to collect the stool test, and 4 times more likely to prefer FIT than have a colonoscopy. Patients in London were only half as likely as those outside of London to prefer FIT to colonoscopy, and the preference of FIT over colonoscopy increased with age. Willingness to use FIT again in the future was stronger in patients who successfully used it, and from those from white compared to non-white backgrounds. And patients who used any type of fecal test were twice as likely to use FIT again in the future. We see, therefore, that most patients with suspected colorectal cancer symptoms who used FIT found it was acceptable, and it didn't generate negative fecal aversion feelings. However, there were differences between patient groups. And this study provided insight into the attitudes and perception of those symptomatic patients who had the opportunity to use FIT, and a group whose views really should be considered when designing and introducing new FIT clinical pathways. So next slide, please. So now I'll go on to discuss how I personally got involved with research. I had a little research experience, having done a medical education MSc, and was nearing the end of my third year of registrar training. And I knew I wanted to get involved in colorectal research. Croydon Hospital, where I was working, does have a strong research pedigree for the colorectal department. And I had a separate project looking at preoperative fitness of colorectal patients set up. And unfortunately, or perhaps fortunately, I couldn't get funding for that, so I looked at further opportunities. Mr. Ablafi, a colorectal consultant at Croydon, was the lead for the NICE-FIT project already, and another clinical fellow was who helped set up the study was stepping down, so there was an opportunity for further research. In addition, Professor Helen Ward, who's a professor of public health epidemiology at Imperial, was also running the Patient Experience Research Centre, which had links to RM Partners and also carried out extensive patient research and patient involvement work, and was helpful in setting up the project. Next slide. So the fellowship application process was rather quick, as there was an urgency to start the project. I first met my two supervisors to get an overview of the project and create the proposal. And it was quite a rapid learning curve, as I hadn't had much experience of FIT during my clinical training. The interview panel was to RM Partners, stakeholders and senior clinicians, and actually I did find it useful in helping me going forward to identify key aspects of the project to focus on. Next slide. So what did I learn during the fellowship? Well, first of all, it was a great learning experience, particularly through collaboration with other specialties and other research groups, which I wouldn't have had interaction with during surgical training. This included biochemists, research nurses, NHS management, epidemiologists, and even anthropologists through my work with the Patient Experience Research Centre at Imperial. Next, I was able to experience the application of clinical research into clinical practice through the FIT implementation project. And this project followed on from the NICE-FIT project, which aimed to translate the research findings into clinical practice to determine the efficacy of a new 2-week wait pathway, which included FIT in primary care to triage patients with both high and low risk symptoms suspicious of colorectal cancer. So we can see the pathway in the slide here. And this was possible because of RM Partners' links to the Croydon CCG in South West London, and also links to the local biochemistry laboratories within the CCG. In this study, patients with high and low risk symptoms of colorectal cancer were tested with FIT, and those with fecal hemoglobin above 9.5 were referred to secondary care for further investigations. Crucially, these results were tracked, and primary care were prompted to refer if timely referral wasn't made. So the study showed that novel FIT pathway can be implemented successfully in primary care to identify symptomatic patients who are at highest risk of colorectal cancer. Crucially, infrastructure that allows good communication between primary care, secondary care, and pathology laboratories, including routes for GP referrals with significant concerns, is essential for successful FIT implementation. The diagnostic accuracy in this real-life pathway was comparable to that of other research studies, including NICE-FIT. And helping set up the pilot study and experience the hurdles that needed to be overcome to change the clinical pathways was really illuminating for me. Next slide. A really important aspect of the fellowship was the opportunity to interact at depth both with patients and members of the public to explore their views on the FIT test and to help rule out colorectal cancer. One of the ways I worked with the patients was conducting interviews to further explore the variation in acceptability and usability of FIT. And interviews were conducted with patients who were part of the NICE-FIT study. And they gave me the opportunity to get insight from patients, which brought up patient factors not previously considered. For example, fears of patients that return the FIT test to the GP would actually add to GP workload, with one patient saying, GPs are so busy these days, even just dropping off a sample is more hassle than posting it. As well as patients, I was able to interact with members of the public interested in colorectal research through simulation scenarios carried out at the Imperial campus, and one of which you can see on the slide, and also colorectal workshops with patient research groups. Next slide, please. So how has the fellowship helped my career? Well, first of all, it's given me the opportunity to publish in peer-reviewed journals and present at a number of conferences, and I particularly enjoyed those from other specialties such as gastroenterology, biochemistry, and also the Macmillan Primary Care Conference. I've got continued links to ongoing research projects related to FIT in Croydon, which also link to the latest colorectal pan-London changes. In addition, as surgical registrars, we only really peripherally interact with NHS change, and often perhaps for short periods of time. So having been involved in a pilot study set up to implement FIT and followed through the project, going through to its conclusion, it's been a valuable learning experience, which I can take forward to further surgical projects. Finally, the fellowship really let me get a better understanding of an aspect of colorectal disease, which I wouldn't really been possible otherwise going through surgical training without research. Next slide. So I just wanted to finish by highlighting some tips for surgeons wanting to do research. First of these is to talk to people about your research if you're interested. So this includes your supervisors, consultants, but also training program directors. And once people know that you want to do research, you'll be in their mind when projects arise. And often program training directors will know of research opportunities across wider regions and will be able to link you with these centres. Another tip is to get involved with areas of research you hadn't previously considered. So my PhD wasn't in the Division of Cancer and Surgery here at this Map of Imperial at St Mary's campus. If you click, if that's okay.
That's negative.
So it wasn't there, it was here. And if you click again, so it was in the School of Public Health and Epidemiology. And this meant that I was close to other research projects going on and was able to observe research projects of national importance, such as some of the COVID studies run from Imperial and the REACT study, which tracked antibodies, patients with the COVID antibodies in the community. So this didn't have direct application to my studies, but did give me a greater breadth of understanding of a fast-moving research project. One other tip I give for surgeons is to keep up your operative skills. So I was also on the on-call rota at Croydon, which meant I could continue emergency general surgical operations, clinics, and some endoscopy. Next slide, please.
That's fine. Good.
Last slide, yeah. So finally, what would I do differently in the fellowship? So first of all, I said it's important to keep up your clinical skills, but it's also important to ring fence research time. So consolidating clinical duties into one day is often useful, and then you have a whole day of research time after that. And next to it, write up as you go along. Whilst I know everyone told me this and it's hard to do, I'm still working the evenings writing up. Finally, I think it's important to take every opportunity you can to speak to and work with patient groups. And this applies to most research, even if it isn't patient or a focused one. And the public often let you consider research questions from a new perspective, which can further direct your work. That's it. Thank you very much.
Yeah, that was great. Thanks very much indeed. Just to remind people on the line to ask questions if you can on the chat line, and then if you open the chat line at the top of the bar, you'll then be able to open a sidebar which allows you to put in a question. So please submit questions. I've just got one question, Theo. I probably asked you before, but the findings that I think are very important that you found in symptomatic patients, of course, the question is to what extent will they apply in the very big field of FIT testing as for screening in the asymptomatic patient? What would your view be on that?
Well, I think they are comparable, and I think with screening, the thresholds for referral for fecal hemoglobin level ideally would be as low as possible, and that really reflects the thresholds for symptomatic patients. The two groups are slightly different because symptomatic patients know that you're looking for something, and so when they receive results and have further investigations, there's a different set of concerns for those patients. But really, interaction with FIT and the implications of patients' attitudes to FIT really do apply across screening as well, I think.
Okay. One question from Arnie. And
Yeah,
then one from Mick, and then we'll start. No.
Thanks. Like Mick, I don't have access to the chat box here, so forgive me for just putting my hand up. So thank you for that, Theo. My question is the finding about London patients being less likely to prefer FIT compared with colonoscopy. Is there an ethnicity reason for this, or is there any other reason?
Yeah, that's really interesting. I mean, we didn't actually find variation by ethnicity. The big caveat to that is that it's the numbers of patients from separate non-white ethnic groups were smaller. So the overall number of patients from non-white groups, you're able to extrapolate and say, well, we couldn't see any clear differences in ethnicity. It may be that within different kind of non-white ethnic groups, there are some differences. But the interesting finding was we didn't clearly see that in the research. So there's obviously other factors going on that affect London and kind of non-London patients. And that may just reflect a very urban area compared to areas that are less urban. So it doesn't necessarily just mean London, but it does mean there's something else going on.
Thank you.
Thanks, Mick.
I'm happy to come back at the end if you want to move on at the moment, Stan, whichever you prefer.
Well, why don't we do it now while we're on the topic quickly?
Yeah, it's a problem with quantitative research when you do a questionnaire, send a questionnaire, you only get a third or less than a third responses, and then of that response, 70% have already had experience in the test. So I wondered how you, when you're trying to develop policies and how you act upon those sort of results, how you take account of that bias that there has to be there to some extent.
Yeah, I completely agree. So I think one of the things we did was to have a look at the general demographics of those patients who couldn't respond on a kind of top-down view, and they were broadly similar. And I think other research I've done is not only looking at patients and doing more in-depth interviews with patients, is also doing workshops and simulation with members of the public who have a slightly different perspective, as they aren't directly patients. Often those people who volunteer are previous patients. So I think getting further in-depth qualitative analysis is also important, and also acknowledging that people who respond are more likely to have particular sets of views. And I think as long as you acknowledge that and kind of account for that in your analysis, it's you can make some valid conclusions.
Yeah, that's great. Thank you very much.
Okay, I think we should move on. There's one other question. I can't see who that's from. Sonia. Is that somebody who can't use the chat line? Sorry, Sonia. Can you put that? We can't. I think you might not be able to speak because you're not one of the speakers. Could you put that in the chat line, Sonia? We'll come back to. We'll certainly come back to that in the panel discussion. Because Sonia, we can't. We haven't got a line open to you because it's not a speaker. I think if Tom had a question, I'm not sure, but if Tom had a question, we can pick that up in the discussion if that's all right. Tom, did you have a question?
Yeah, that's fine. If you can hear me, we can do later on.
Sure. Yeah. Okay, good. All right. Well, we'll have plenty of time for that, and we'll make sure, Sonia, that you can get your question in. Okay. Thank you very much, Theo, and we'll come back to that in the presentations. We're now going to move to another surgeon. This is Rebecca Bott. Rebecca is a surgical registrar at St Thomas's. And she's been the recipient of an RM Partners Fellowship Programme, and she's been working in the area of upper gastrointestinal cancer. So, Rebecca, looking forward to hearing what you have to say.
Okay, thank you. Thanks for the invitation to talk today. It's a really nice opportunity to be able to chat through the use of the fellowship. You can go to the next slide straight away. So yeah, I'm a senior registrar, much like Theo. I'm currently on the South East London rotation, and my subspecialty of interest is upper GI surgery, particularly the cancer field, both for my clinical work and for research. Throughout my training, I've been involved in some sort of small scale projects, doing a few presentations, and I've had the odd publication here and there. But I also didn't have a huge amount of research experience, but was very keen to kind of step into that world as I progressed through my registrar training. And in the early years, after I'd done 2 years of clinical, I decided that probably doing some research work would be good. And the first thing I did was to undertake a part-time MSc at Imperial, which I did alongside my full-time clinical work. And it was through that really that my interest in doing research and bigger projects came about. I was able to do some project work at St Thomas's, albeit that my degree was over at Imperial. So we already started to do some collaborative work then, which was great. And that was looking at some preoperative scoring systems that we use in the esophagogastric cancer patients. And it was through that work and with my supervisors at St Thomas's that I started to develop an interest in the idea of doing some bigger work and potentially a higher degree. And at the time, I didn't really know how I would make that work or what options were available to me. And through some good supervision at St Thomas's, one of the supervisors came forward and explained to me about the Pan London Cancer Alliance's research fellowship. And I started looking into it and seeing what was available and how it worked. And through that, I decided I was going to apply for a full-time MD, and I wanted to take some time out of my clinical training to do, some focused academic work that was what I applied to do through the University of King's. And at the time, I then applied for the fellowship as well. Next slide, please. So through finding out about the fellowship from my supervisor and reading through the information, it became very clear that some of the ideas that we'd come up with really aligned and matched to the Vanguard work streams that had been advertised. And so it was a natural progression to then say, well, based on the project we were thinking about, we would apply for the fellowship because of how it aligned. So my project title was actually different to this originally, but as with all research, these things evolve over time. And my final title after a few months of work was Assessing Esophageal Cancer Patients as Responders and Non-Responders, and can we modify patient treatment strategies, specifically neoadjuvant and adjuvant therapies, to optimize pathological, clinical, and functional outcomes. I wanted to do 3 sort of main research studies, and a big pull for me was that through St Thomas's, who already had a relationship with RMP and the Royal Marsden, we wanted to do some collaborative study work that meant not only collaborating with associate supervision, which I was able to do with one of the surgeons there, but also to set up a bit of a surgical trainees research group, because I'd felt that through my surgical training, everybody was sort of doing little projects, but we were all talking about what we were doing, but nobody was really working together. So this seemed like a great opportunity to do that. My MD thesis was to combine all the studies with a common theme, and the title sort of explains I kind of wanted to look at the whole patient journey. So I wanted to look at something before they had their surgery, the treatment after their surgery, and then the outcomes that followed on from that. So the project themes that matched at the time, there was the Achieving World Class Cancer Outcome paper in 2015 that looked at some of these topics. And we found that the ideas we had matched really nicely with improving survival through early diagnosis and detection, focusing on older people with cancer, because the OG sort of cancer cohort tends to be a much older population. And then also optimizing the management of patients surviving with cancer during and after their treatment, because the results for the OG world have improved in the time that I've been involved in the research. And it was nice that they all seemed to fit and align with the work streams for what we wanted to do. And much like Theo, you know, I wanted to sort of publish, present some work, and just develop my research skills. It was something that I hadn't really had an opportunity to do other than alongside my clinical work. So it was nice to be able to give that focus. And I hope to be able to attend a few meetings and network across the upper GI field, which the fellowship has certainly given me the opportunity to do. Next slide, please. So the 3 studies that I proposed and then went on to do were as follows. The first study looking at neoadjuvant chemo was predicting pathological response, responders versus non-responders, and the importance of clinical factors. So we wanted to try and identify if there was anything that we could look at that sort of was predefined that would allow us to see who was responding and how they may benefit in terms of the whole journey. And then that followed nicely with study 2, which was to look at the role of adjuvant treatment in patients with resectable disease. Now, there's not a lot of stuff out there at the moment in the world of upper GI cancer. There's no consensus around adjuvant treatment. It's still very much discussed in lots of different ways. And we wanted to look at, with the collaboration, we wanted to look at 2 big centres in London who could pool their results together and say, well, what are we actually seeing? Who is benefiting, and how can we use this clinically? And is this something that we can take forward? So we wanted to see who was benefiting and what came out of it in terms of survival and recurrence. And then the third study, which was to look at sort of the end outcomes for patients, was all about functional outcomes after the treatment process. And we looked a little bit at risk prediction, and then mostly at things like quality of life resolution and how this correlated with their survival outcomes and what was actually important to the patient. And this study area, which is actually still ongoing at Tommy's, has been a big learning point for me. Particularly with the patient contact around, you know, it isn't just about telling patients that they're going to live for X amount of months or potentially years, but what they really want to know is, in that time, can I swallow? Will I be able to get out of bed? Can I live a normal life? And that as a clinician has been hugely interesting. So they were the 3 studies to make up the thesis, and they were the 3 projects I completed in my couple of years whilst doing it. Next slide, please. So I think it was important to highlight for, you know, other people thinking about, you know, doing this, is that we are the people that do the research and it's our name that goes on the paper, but there's this sort of enormous team behind us. I've had amazing supervision from the team at St Thomas's in terms of my clinical work, but then going forward with the research, not only with the original ideas, but supporting me through doing the degree and all of the project work that I did. I had a university supervisor who was based at King's, but it is from the Karolinska Institute in Sweden, and that has actually developed into a relationship where we've collaborated on more projects, and that's led to more work. And I'm looking forward to when I return to my training this year, you know, picking some of that up again. The associate supervision I had from the Royal Marsden was fantastic. It meant I could go across to a different site, not only for the research, but I had the opportunity to do some clinical things over there. And what was lovely was that I had surgical colleagues over there who collaborated on the project and have now been part of a research group, and we've formed our own little collaboration where we meet regularly now to discuss projects and do work together. You have a committee obviously from the university who help and support you, and then I also had a huge amount of support from the research team at the hospital, as well as statisticians. I actually worked with a number of radiologists, people from different departments who I guess I hadn't quite anticipated that I would develop those relationships. But I think one of the best thing about doing both the fellowship and the research for me has been the people I've met along the way and the sort of relationships that I've forged. So I owe all of them a big thank you for the output that I reached. So next slide, please. So just in terms of the timeline and how it worked for me, I applied for the fellowship in May 2017 and found out not long afterwards that the grant had been awarded. And on knowing that, we were able to plan the project and kick things into gear pretty quickly. And I started the work in September. In October, I came completely out of my surgical training. I took what's called an UPA, an out of program research break, for a full 2 years for me, because I wanted to do the full MD with the work using some of the fellowship funding. What it allowed me to do, which was just fantastic, was to be able to do a full-time academic post. So I too was able to do some additional and ad hoc clinical duties to keep up my clinical skills, because I think as surgeons, obviously it's important to keep that going. But it was actually really nice to give the academia the time and focus it needed. And that really helped me in terms of getting the work done. And I'll talk about writing up the thesis, but I agree with Theo, everybody tells you to do it at the time, and it's just being academic in the way I did it actually worked really, really well. I returned to surgical training in April 2020, which I'll come on to a few issues that I faced later, because that was, I'm sure everybody remembers, at the height of the pandemic. But my project work was ongoing and I was writing up at that time. And I submitted my thesis in July and I was awarded my MD towards the end of last year. I'm now in a position where I'm doing further ongoing research, and one of the projects, the third project I discussed, we've got shared projects now with further MD students through St Thomas's that are going on to kind of bigger projects that I'm involved with. I'm now also supervising some of the junior research projects at St Thomas's, and we're still collaborating with the other centres. Next slide, please. So in terms of outcomes for me, in terms of the fellowship, I haven't gone into the nitty-gritty details of the results of my projects, but the things that kind of I've done and that I feel have been hugely important in terms of what I've achieved, the fellowship and the funding allowed me to probably go to a lot more and a lot more distant conferences than I would have done on a normal surgical training budget. I did some presentations, both poster and oral. The nice thing about being academic and having funding is that you can then travel a bit. So I went off to Prague and Athens and Liverpool all in about 9 months. And it was just a fantastic opportunity, not just to present the work that I'd done and highlight it within the field, but to meet other clinicians, you know, and to network for my career. So that was a fantastic opportunity. Next slide, please. It's been really great to publish work. I did have some publications before I started, but I think that doing the MD and the research that the fellowship has allowed has definitely pushed me forward in doing some bigger pieces of work and publishing in higher powered journals. So that's been huge for my CV. And I'm now part of what's called the Guy's and St Thomas's Esophagogastric Research Group. So any of the team who go through and publish work, we're all part of the network group, and we review it and edit it, and then we're all included. So that's been a really, really good thing for my career too. Next slide, please. And obviously, you know, the main thing for me was to get the higher degree, which I'm really chuffed to say that I've now completed. My thesis was of a very similar title, looking at the responders and non-responders, and we were looking at neoadjuvant and adjuvant therapies in esophageal adenocarcinoma. And through doing the MD, one of the things that I guess I hadn't really anticipated when I embarked on the research was the personal development and the taught module side of it that I would benefit from. So I was able to do lots of courses. Having been terrified of statistics my whole surgical career, I've now done you know, quite a lot of teaching in that, and I feel that that's really strengthened you know, my abilities, and something I certainly wouldn't have done had I not been doing the research. Next slide, please. And one of the nice things for me, having attended, we have a meeting through Guy's and St Thomas's. They do a cancer research group meeting, which is some of the other hospitals and people attend from around the country, and it's held at the Houses of Parliament. I'd attended it twice. I'd been asked to go and you know, as the audience, but what was really nice was that when I finished my research, they asked me to go and present my work. So that was an amazing opportunity to talk in the Houses of Parliament to other colleagues. And as discussed earlier, the collaborative research group amongst the trainees and research fellows, not just surgeons, actually, we've done it with some of the medics and the radiologists as well, has been great. We meet regularly. Some of us go for dinner. That's been a huge bonus. And then there have been 4 further MD students who followed me at St Thomas's doing similar things, who I'm either supporting and doing shared projects with at the moment. Next slide, please. And then just to finish, obviously these things don't always go smoothly. For me, there was a few what I call bumps in the road. The first was that I had my first child during my academic year. So I took 6 months maternity leave after my first 12 months of the fellowship. And actually, this just worked really well. I was able to carry on some academic activities. I feel like the funding gave me the flexibility to do these things, which, you know, surgical training, it can be quite challenging to fit these things in, but that worked well for me. The other big bump and the hurdle was obviously the pandemic. And when I returned to my training in April, I was meant to have some academic time, but unfortunately that was stripped because I had to do frontline work and clinical commitments. So on 2 occasions over that 18 months, I had an automatic extension deadline and a pause on my studies from the university. And that's challenging because I think when you're pushing forward with your projects and you're doing well, you kind of want to keep up momentum, particularly when you're writing up. But for anyone else who's thinking about doing it, I had a lot of stop-starts for a variety of reasons, but I got there in the end. And actually these hurdles, you just have to, you know, take them for what they are and face what you're doing at the time and keep going. And I'm pleased to say I've had another bump in the road. Baby number 2 arrived, thankfully 4 weeks after my Viva, not before. So these things are all possible. So it was just to highlight, as a woman in surgery where we do face some difficulties, these have been my hurdles, but they were all easily jumped. Next slide, please.
Last minute or two, Rebecca.
Sure. So I think this is my last slide. So my overall experience, obviously, the funding's allowed me some focused academic time and a bit of a break from my surgical training. I was able to concentrate on the academia, which has been fab. I have kept up some clinical studies throughout, which is important to maintain your skills. It's really nice as a clinician to do the research and feel up to date and evidence-based in your practice. I've attended conferences and done lots of traveling and lots of networking, and it's been fantastic collaborating with colleagues. And it's a really nice thing for me to see other students coming through, following me at St Thomas's, and being able to turn around and help them like the guys before me did. Last slide, please. And that just shows you our group of that was us in Athens, both presenting, and then my little boy who I took with me, both to Prague, Athens, and Liverpool. Thank you.
Thank you very much, Rebecca. Well done. And it's great to hear that you've demonstrated what can be done while having 2 babies, 2 baby boys. Great. I think we've got in the chat line, we've got a question from Mary Wells. And what Mary's said is really interesting work, Rebecca. Did you look at any forms of prehabilitation in terms of response to treatment? Or were you looking at clinical factors primarily, or socioeconomic and psychological factors?
Okay, thank you for the question. Yeah, we were looking at predominantly clinical factors. There has been some prehabilitation work done out of St Thomas's, but that was done separately, and I didn't really overlap that with my work. In terms of the clinical factors and how they impacted with the neoadjuvant work, we looked at things like changes to dysphagia, changes to patient weight, and then we also looked at some CT findings both before and after treatment, so changes in volume, scoring for the response in terms of how they've responded to the chemo. And we did also look, interestingly, at things like lymphovascular invasion for afterwards, and how we could, whether there was any option to apply that, as a predefined thing or not. So it was predominantly clinical, but those other things I think are certainly things that should be looked at and under consideration. And the prehabilitation work that's coming out of Imperial and St Thomas's, is obviously been really, really good over the last few years.
Absolutely. Absolutely. I think two things. Question for Mick first, Mick Peake.
Afternoon, excellent talk. Thank you very much. I'm a lung cancer guy, and I know how difficult adjuvant studies are. They need large numbers and take very long time. And by the time you've got the answer, things have moved on. So I wondered the extent to which your work could help you define early markers of the efficacy of. Do you think it really will impact the ability to identify effective adjuvant therapies without the need for such a long-term, high-volume trials?
No, I mean, I think it's a really good question. So the adjuvant work, the good thing about it was that we did have really big numbers because we had the 2 sites and we looked at a period of, I think it was just shy of 10 years. So we did have really good numbers. But as you say, you're looking at things that happened before as opposed to at the time. I think the work that came out of it and the results we had, we looked at differences in survival. We had some really interesting results about survival being better in some people who were non-responders, which was a bit unexpected. But I think to have true clinical sort of applicability and to translate that across, like you say, you need big numbers, you need it to be at the time. It's really, really difficult. I think we can only look at it and reflect and try to apply it to practice.
Thank you.
Thanks very much, Mick. Any other questions of Rebecca? Anything in the chat line? I think we've covered that. Just to go full circle, we have had, I think we've had coverage. I don't know whether Theo's still on the line, but Theo has online answered 2 questions on his previous presentation, one from Sonia and one from Tom Round. Theo, is there anything you wanted to say about those, just to cover that off?
Yeah, so I think one of the questions was about fit tests that have been done in primary care which haven't been processed, and then issues with referral under the 2-week wait pathway. And the first thing to say is that a decent percentage, so between 15 and 20% of laboratory fit tests in symptomatic patients at Croydon were initially rejected. And we asked the GPs to re-refer patients who had a rejected fit test. But at the same time, I think a crucial part of the pathway was having a direct referral element. So GPs could refer patients who hadn't had a fit test, whether that was because they had urgent clinical concerns or because it couldn't be processed, and allow them to access the 2-week wait pathway quickly that way. And I was saying in the chat that in the patients who had a high fecal hemoglobin, compared to the patients who were referred directly because of clinical concerns without a fit, there was actually a comparable cancer rate. And I think it shows that GP kind of clinical assessment of patients is really important and should be integrated into the pathway alongside having fit for as many patients as possible.
Okay, thanks, Theo. I think that we'll move on because I think Tom, the other question was a dialogue with Tom, who might want to bring that up in his presentation, if that's okay. Or was there a point, Tom, that you wanted to make in your question that you wouldn't be making just now?
Later on, I don't want to, but that's a really good answer. Thank you.
Okay, then. Well, we've got one more presentation before our break, and it's from Tom Round, who, as you can see, is a GP and NIHR doctoral research fellow. I'm sure that we're looking forward to hearing Tom's talk. Primary care referral for suspected cancer. Mixed method investigation goes back some way into variation and outcome. So we're looking forward, Tom, to hearing from you.
Great, thank you. Just checking you can hear me okay, because I'm in my clinical office today.
Fine.
Good, you can hear me okay.
Yeah.
And you probably see the XX Place, but actually that used to be that's one of our practices in East London. I work in a large 3-practice partnership in East London in Tower Hamlets, about 30,000 patients, quite a deprived area. We've got quite a few people off with COVID, so that's why I'm covering clinic today. So thanks for being slightly flexible with me. So yeah, I'm going to talk a little bit about my research, which started a couple of years ago now, pump primed by a RM Partners Award and then an NIHR Doctoral Fellowship. I'm headlined here. This was actually presented as one of the leading talks at the World Organization of Primary Care, that's WONCA, that was in London last week as a joint conference with the RCGP. So that was great. We had a few thousand people there and presented some of this work. The next slide, please. Some of you be aware of this work, which is the International Cancer Benchmarking Partnership. This was the most updated study published in The Lancet, which shows, you can see that UK is in red and showing all countries are doing a bit better over time. So this is showing difference in 5-year survival. We've had a number of waves of the International Cancer Benchmarking Partnership, and this, you can see there, whilst there has been significant improvements, UK and England are particularly outliers compared to other comparable high income countries. Now, there's a lot of speculation why that is and research into this field. You can see that UK and Denmark historically have worse outcomes. This has been postulated maybe be too strong a gatekeeping in these countries and lack of diagnostic access. So really, if you look at this in terms of what does this difference mean, a headlined research paper, which is widely cited a few years ago now, shows potentially between 5,000 and 10,000 lives could be saved per year if our survival rates match the best in Europe. Next slide, please. So we have this what's called the interval for symptomatic patients. So we know that majority of patients, about 90%, will present symptomatically to primary care. Roughly about 5 to 6% of cancers are screen detected, but majority of patients are symptomatic presentations. And you can see there that you can have potential delays anywhere in that interval. So you could have patient level delay, and that could be maybe watching and waiting, maybe asking other healthcare professionals before accessing primary care. Then we have the initial contact with primary care, and we know that particularly there are access issues, and maybe these are getting a little bit worse. We do have a primary care workforce crisis. I give a rough idea that we have about 7,000 practices in England. Each one is short of 1 GP. So that just puts it into context how bad the situation is. Obviously, we have that contact with your primary care professional. They might do an assessment, maybe do fit testing, blood testing, etc. Then make a decision to refer. And then obviously you can have then diagnostic interval and maybe secondary care or system level delay. So, and are these important? Well, there is systematic review evidence showing that if you do prolong either primary care or secondary care treatment intervals, you do have worse outcomes for most cancers. So I think it is important. And we also know that if you are diagnosed with cancer following a GP referral, you are generally at an earlier stage and better outcomes than if you have some kind of emergency activity. Now, that's not patients diagnosed in A&E, it's someone having some kind of emergency room activity. Generally, older patients are a bit sicker. Next slide, please. So, yeah, I mean, I've been training as a GP for a while now. So I remember actually when I first trained, this was the 2005 guidance that we had for suspected cancer. If you look back at this document, we talk about the PPV, positive predictive value of cancer, was around 5% or more, 5 to 10%. It was mainly based on red flags. Next slide, press down again. So we had the updated guidance, which came in 10 years later, and that was primarily due to a lot more primary care based research in this field. Colleagues Willie Hamilton, who chaired these guidelines, Fiona Walter and other colleagues, did large case control studies using primary care data. And that really showed that it's not just the red flags, it's a spectrum of symptoms and actually combination of symptoms. And for the first time, this guideline, and it is a very complicated guideline, it had a threshold of around 3%. So not just your red flags, which are typically 5% or more, but also could you have some vague other symptoms that could be due to cancer. Next slide. And that just shows, this is the BMJ trying to summarize just a little bit of this guideline, just shows how complicated the world of clinical medicine we work in. This is looking at potential different symptoms that could be linked to multiple different cancer types. I would say the NICE guideline was the most complicated NICE guideline ever produced, about 400 to 500 pages. And it just shows what the complicated world of symptoms and assessing these symptoms and signs in primary care, making a decision then about what could be related to cancer. As a rough idea, if you're a full-time GP, you would have around 8 cancers a year, one of the top 4 main cancers. you might have one ovarian cancer every 5 years, but potentially hundreds, if not thousands, of consultations that could be due to cancer. So it's really about how you assess this and make that sort of gut feeling and use your clinical acumen along with tests in primary care. Next slide, please. So the start of this journey, I was at a presentation from a colleague, presented this piece of work published in the British Journal of General Practice, looking at the variation in how GPs use urgent referral. Each one of those little dots is a GP practice in England. So you can see some practices along the bottom axis, that's your standardized referral rate. They're referring twice as much as other practices. Some are referring about 50 to 75% less, but also a big variation in how much cancer we're picking up. And we call that the detection rate. So in a way, that is your sensitivity of referral. So that's how many of your cancers for the year are you picking up via the urgent referral pathways. We call it 2-week wait, but this might be changing in the future to rapid diagnostic or rapid referral pathway. So that kind of led to some questions about which one of those little dots is my practice in East London where I'm working today, but also what's driving that variation. Is it something around clinical decision making, or other practice or population factors could be driving that? But also importantly, we're using these pathways a lot more. What is the evidence base for improved outcomes? Next slide, please. Which then led on to this piece of work where we linked that cohort. That was a cohort of around 200,000 patients. We then stratified them based on their GP referral patterns. So for the first time, linking individual cancer patient data to their GP data. In collaboration with Public Health England, now changed to NHS Digital. So that showed for all cancers combined improved outcomes if you're a patient from a higher referring practice. However, this also led to further questions. This is only for 1 year's data. It was for all cancers combined. What about the main subtypes? Also, you could improve outcomes, but how much of that is due to stage, or could there be some observational bias there? So that then led to my RM Partners Fellowship and then to the NIHR Fellowship. Next slide, please. So our aims, we did 3 linked studies using mixed methods. So study 1 was, rather than 1 year's data, we took a 5-year cohort that was 1.2 million cancer patients and linked the individual patient level data to their practice level data for all cancers and for the 4 main cancer types, and also included stage within that. The second study was looking at what primary care practice characteristics, population characteristics could be driving some of that variation, and it also change over time, over 10 years as a national cohort study. And then study 3 was utilizing this quantitative data to inform a qualitative study. Now, we found when we'd done reviewing the evidence and the literature that most studies were with patients. There was relatively few with healthcare professionals, but also none that had combined both patient and healthcare professionals across primary and secondary care. So we did a sort of like a max qual study from both patient perspective, primary care, including not just GPs. So most studies, again, were just with general practitioners, but thinking about the wider primary care team. That's why I've said healthcare workers there. I think that's really important, not just consultants or GPs, but actually thinking anyone who's running the cancer referral pathways. Next slide, please. So we published some of this work. So this is the first study published during the pandemic in 2020. This was our 5-year cohort study. So really finding a similar trend to what we found in the BMJ study, that for all cancers combined and improved, so if you're a patient from a high referring practice, you have improved outcomes, and potentially about half of the observed mortality difference is due to earlier stage diagnosis. However, there was a differential effect on different cancer pathways. So I've got there colorectal, lung, breast, and prostate. So we actually found less of an effect for stage for increasing colorectal cancer referrals. So you can just put the next, if you just press, I think my text has come up. Yeah, so that was similar pattern to that. And then next, yeah, and this is due to early stage diagnosis for colorectal cancer. So that's really showing that we're increasing referrals. That does seem to be making a difference, improving cancer patient outcomes, so including reducing mortality, but also earlier stage diagnosis. But that doesn't seem to be the case for colorectal cancer. I think that's quite an important finding, and it has been highlighted in some of the FIT studies linked back to the previous speaker, which I think is important. We might come to a discussion point later on. Next slide, please. Then we published this piece of work. The next study 2 in, again, British Journal of General Practice was published last year. And really, this is showing more than doubling of referrals. So going from 900,000, this is pre-pandemic data, up to 2019 to 2.2 million. I would say also during the pandemic, we saw a drop off about 300,000. So in the pandemic year, about 300,000 drop. I would just say hats off to everyone who's been working in the NHS for the past year, because we have shown a record number of referrals. They've gone up to 2.7 million. So hats off to primary care and secondary care colleagues working in a lot of pressurized environment, actually really upskilling this and increasing these referrals. And what that has shown in the red line is that we've increased our detection. So that's the amount of cancers picked up via these pathways has gone from just over 40% to 52%. And if we link back to the previous work, that probably will mean that there's improving outcomes for these patients. We showed a relative increase of over 60,000 cancer patients 2009-10 compared to 2018-19. Can just tap next slide, please. So, just go back. Can you go back one? Sorry, that's just a little bit. Sorry, this is where I've got the little clicker myself going through the text. But so we also looked at practice characteristics and population variables that could be associated with higher detection. And we did a linear multiple linear regression models. So again, talking about stats. So stats was something I really wanted to get out of doing this fellowship and our doctoral fellowship. So really got a lot better at using data and using large data sets. So we're talking about multiple millions of patients and multiple million data sets. We found actually that the higher detection was associated with larger GP practices, and that was statistically significant throughout the 10 years. And with younger GPs. So younger GPs seem to be referring a bit more and picking up more cancer. Now, interestingly, this and the GP age was the most correlated throughout the 10 years of this study. It did become attenuated over time, so that maybe shows some diffusion of nice guidance into practice, so less variation between individual clinicians. But I think, important about how we might focus potentially interventions to certain GP practices who maybe are referring less, picking up less cancer. Also, interestingly, we found deprivation was associated with decreased cancer detection in more recent years. So I think really that's showing something called the inverse care law, which we know if you're in a deprived practice, you get less funding per capita per head of population. We also show maybe less GPs, more workload, and also less cancer detection. So really a policy sort of arm to this work there. Next slide, please. Thank you. So then we used the quant data to inform qualitative study. So we looked and interviewed both patients and, as I said, healthcare professionals, healthcare workers. So we found a number of themes, which we're writing up into a third paper from this piece of work, which included the influence of pre-existing problems, bodily changes, and self-care management, and advice from others. So maybe other members of the family who had similar pharmacists, etc., before accessing primary healthcare. Healthcare professional factors included time, so we know how busy people are and competing priorities, the importance of safety netting, and gatekeeping and pressures on referrals across both primary and secondary care. However, when we looked at more of a system-based approach, we did find, and link the data together, we did find generally positive experiences from both patients and particularly primary care staff that they could utilize this rapid referral, get patients seen without having to wait. And we know how long waiting lists are at the moment. Patients somewhat feeling a little bit lost in the system, maybe a little bit of anxiety and stress. You've had a comment maybe from your primary care professional that you could be investigating, potential cancer symptoms. Did have a little bit of anxiety in some of the patients, particularly when they were waiting for maybe MRI scans or other scan results. So they kind of had a fast-tracked initial appointment, but then they felt a little bit lost waiting for a final results. And of course, we know how finite resources and pressurized the healthcare system we're working in. Next slide, please. So really a little bit of summary, and we also asked about ideas for change from this piece of work. So we found quant data and qualitative data supporting the NICE 2015 guidelines, but really thinking about the differential impacts of 2-week wait pathways. And that could include, as I say, less of an impact of increasing referrals for lower GI, more of a need for rollout of FIT testing and other triage tests in primary healthcare, and really thinking of supporting secondary care and primary care working together. There was this really interesting notion that if you are, especially a patient or healthcare professional, if you have a patient, for example, with rectal bleeding, change in bowel habit, you'd want to know if they have inflammatory bowel disease as much, and also cancer, could, thinking about serious pathology. So actually, really, could we utilize these urgent referrals, not just for cancer, but for any type of serious pathology that we're worried about? There was also an interesting concept around utilizing wider teams. I think there's a really key piece of work about improving training and recognition of cancer for other primary care workers, not just GPs. You might have heard in the news about pharmacists maybe being able to take on red flag symptoms. We've got expanding workforce in primary care, including physios, social prescribers, etc. So really thinking about the training needs for that wider primary care groups. Key aspects is including increasing access to diagnostics. So we know how difficult it is to get a CT scan. So that's really thinking about the rollout of the rapid diagnostic centres. And then how we might utilise this data for quality improvement. So this data is freely available on practice profiles and how it might be utilised for individual practice plans. We also think about this expanding the referral. So I've said about more than 2 million people going through this pathway. Around 7 in 100 will have cancer. That has gone down. So that's a conversion rate or positive predictive value for referral. It's not yet at 3%, which NICE talks about, but we know we've dropped down to about 6 to 7 in 100 having cancer. But what about those more than 1 million people per year who don't have cancer? Could we utilise their experience, because obviously it's slightly anxiety provoking, as a teachable moment? What is their future cancer risk? Can we increase screening uptake in that population? So we've got another research grant from SIR UK to look into that. Next slide, please. Just to summarise, that's where you can go onto practice profiles data. Just click down again if you can, Anna, and that gives you the data at a practice level. So this, we should say I did a sensitivity analysis showing that the patterns we found were similar for London. This is data from North East London where I work, where we've simplified, and I've worked with colleagues at previously Public Health England, now at NHS Digital, to how we might simplify this data and how we might utilise it for practice utilisation. Next slide, please. We probably can say this is the final slide, and this is from Mike Richards' report, the two reports there talking about unfinished business and diagnostics recovery and renewal, and that shows looking at CT per capita, and you can see there UK as an outlier with very low, and this is the same also for MRI and also for endoscopy capacity. I've got colleagues in Australia, and you could see there in the previous graphs, Australia actually has very good cancer outcomes, similar model to the UK with a gatekeeper model with primary care, but more GPs per capita, but also more access to diagnostics. So I think that's a really key discussion point going forward. If we're going to improve our cancer outcomes, we need a whole, both in the workforce and also diagnostic kit. Next slide, please. We can skip through that one. That's just talking about the Rapid Diagnostic Centre. We can maybe skip that one. And then definitely final slide here. This is nabbed from Cancer Research UK, thinking about how we might improve early diagnosis of cancer. So bit I'm kind of looking at is that kind of referral compliance, better pathways for referral, a little bit around supporting primary presentation for the public. But you can see actually that's how we might go from 1 in 2 people having early stage diagnosis to that aim of 75%. But a real clear need for more research into this area, more triage testing in primary care, and thinking about research and innovation into the future. Okay, thank you. Skip that one. Thanks very much.
Thanks very much, Tom. That was great. I'm sure you've stimulated lots of points for discussion, which we can pick up a lot of those in the panel discussion. Yeah. Just in the minute too, before we have a tea break, we've got one from here from Michelle. It's a general question, Tom, about GPs. What's your observation been in terms of the number of GPs pursuing an academic career since you started out your fellowship, versus now? Are the existing workforce pressures a real barrier?
Isn't it? Because we know how stretched, I would say everyone's stretched, aren't they? But primary care are particularly in a bit of a crisis at the moment. Primary care, there's a lot less academics than secondary care, if that's the first thing to say. So as a rough idea, I think secondary care colleagues could come in, or I think around 1 in 10 overall consultants have an academic track. It's a lot less for GPs, historically about 1 or 2%. Also, it's a little bit different. So GP training is obviously shorter. So often GPs will do sort of 3 or 4 years, and then if they've got a research interest, will try and do extra bit of research after that. And that's a little bit harder, because I think actually if you're a trainee, you can extend your training before your CCT. I was lucky because I did a 4-year GP training course. So I did an extra year as a taster, as an academic clinical fellowship. And these have been rolled out a bit more. They obviously are expensive. So we're kind of pushing for, I think it's really important to push the government and the Royal College is very much for this, about 4-year GP training, because I think actually if we're going to be primary care consultants, we need, 3 years I think is too short. I think we're looking at 4 years and a little bit, as particularly people interested, to be able to do a little bit of taster in academic primary care and then potentially pursue careers in that. So I would say things are a little bit better maybe, Michelle, than they were a few years ago. We do have more funded NIHR fellowships for trainees, so FY2s and also those in their ST training, but certainly less than secondary care.
Okay, thanks, Tom. I don't know whether we've got any other questions in the chat line. One question from Arnie.
Thank you, Stan. Thank you, Tom. Great talk. Really enjoyed it. I've got lots of questions. I leave most of them for the panel discussion. My question is about your 40% to 52% increase, higher detection between 2009 and 2019.
Yep.
How much of that is linked to greater incidence of cancer rather than improved detection?
So that's your sensitivity. So whatever you cut the pie, it's like so it's not just it's the sensitivity of the pickup. So basically, if you've gone from say 100,000 to 200,000, you've more than increased. So it's not just, if it stayed the same, we'd have just picked up more cancers just from increasing incidence with an aging population. And the other key thing I would say is that the number of emergency presentations pre-pandemic or emergency activity, as we've discussed before, has dropped significantly. So a lot more patients are being picked up for following GP referral, having, we hope, better outcomes.
Thank you.
So hats off to everyone who's working really hard, including yourselves in secondary care, taking all our referrals. You probably say all these GPs referring everybody, but we're trying our best. And the key thing is gut feeling is very important too.
Good.
Thank you.
Okay, well, I think we're pretty well bang on time. If you've got some more questions, please save them. We're going to have an interesting panel discussion. I think we all need a wee cup of tea. So if you can rejoin promptly at 3:15, that would be great. Thank you very much. Welcome back, everyone. Thank you for rejoining. We've got two presentations now from two of our dietitian colleagues. Claire Shaw will then be giving us her views on supporting AHPs in research, and then we've got lots of issues that we'd like to discuss, particularly looking ahead for this fellowship program. I like to feel that it has been successful, but we do need to think ahead to see what are the things we need to discuss. So let's kick off with Jennifer McCracken. Is that you, Jennifer? Jennifer's going to...
Yes. Hi there.
Hi, Jennifer. You're going to answer the question, what information do patients and carers need to make an informed decision to commence and discontinue parenteral nutrition? So this is now at another end of the patient pathway. Really important for us to cover that in advanced cancer. So Jennifer is a senior specialist dietitian at the Royal Marsden Hospital, and we look forward to hearing what you've got to say. Jennifer?
Thank you. Can I just check, Stan, am I moving on slides or is someone else doing that?
Anna's doing that at this end. If you just say next slide, we'll do that. Yeah.
That's brilliant. Thank you. So hi, everybody. As Stan said, my name's Jennifer McCracken. I'm a senior specialist dietitian for teenagers and young adults at the Royal Marsden Hospital. And I'm currently an NIHR predoctoral clinical academic fellow as well. I'm delighted to speak to you today about my experience of being on one of the RM Partners research fellowships. Next slide, please, Anna. So my RM Partners research fellowship started back in October 2019. And this was awarded for 18 months as a part-time fellowship. So I did this for 3 days a week over that 18-month period. That was slightly interrupted by COVID, but I will come to that when I talk about some of the benefits and challenges of the fellowship. When we presented this idea of the fellowship, I'm supervised by Dr. Claire Shaw, who I know is speaking to you shortly after this presentation. We wanted to look at artificial nutrition in quite a wide context at that stage, which looked at things like tube feeding and parenteral nutrition and all different forms of nutrition in advanced cancer. And one of the really valuable pieces of feedback that I received from my interview was that we really needed to refine the research question. And with hindsight, I can see just how important that has been for developing this research. So with Dr. Shaw and with input from our steering committee, we managed to refine the research question to look specifically at parenteral nutrition, so a form of intravenous nutrition, which has become more common among people with advanced cancer, but only really in recent years. It's not something that is that easy to provide for patients with advanced cancer, due to the logistics of setting it up for people at home. And it is a little bit more complex than some of the other forms of artificial nutrition support. When we looked at what had already been investigated in this area, there seemed to be a real gap around what information both the patients and the carers needed when it came to decision making. So what information did they need to make an informed decision, either to start or also to stop parenteral nutrition with an advanced cancer diagnosis? And we found that there was maybe a bit more discussion around commencing, but quite a bit of sort of hesitation sometimes around discussing discontinuing, and a little bit of lack of clarity of whose role that is to discuss that. So we were very keen to explore that with this study. So we refer to it in its shorthand as the input study, which simply means information needs around parenteral nutrition in cancer. And this was a multi-centre study, so that involved the Royal Marsden as a cancer centre, and also 3 other intestinal failure units within London, so St Mark's, UCLH and St George's, who we worked really closely with their nutrition teams to recruit patients for the study. We also were able to recruit carers wider than just those centres. We opened it up UK-wide, and we were very fortunate to get a grant from the Biomedical Research Centre, which allowed us to produce a video aimed at recruiting carers into the study. So this was a qualitative study. It was all interviews, 1 interview with a patient, with the opportunity for them to add additional comments for the 4-week period after the interview took place. And next slide, please. So I thought it would be useful to tell you a bit about my experience of leading this study. So one of the biggest advantages of this RM Partners Fellowship was that it gave me protected time to embark on research. I hadn't done any research before this. I was a complete novice at research before taking on the fellowship. And so having the protected time and the right people around me to provide the support was absolutely essential. I wouldn't have been able to achieve this study without having time out of my clinical role. And it gave me the chance to learn research skills, so to do additional training, particularly around the qualitative side of the study. So you can see I've said that I've undertaken additional qualitative research training. So that involved training around interviewing patients and carers, and also around analysing the data that we gather in qualitative research and how to deal with transcripts and coding, for example. I've mentioned our multi-professional steering committee, so I was very fortunate to work with a range of experts in palliative care and nutrition, and all from different backgrounds, clinical, academics, a number of the team who were fantastic at giving me the guidance that I needed around things such as qualitative data analysis. We worked very closely with a researcher in Southampton so that I could learn the ropes of qualitative research, and actually spent some time at Southampton University, where she was based at the time, to brush up on those skills as well and learn from one another. The other thing that was a fantastic opportunity with this particular fellowship was learning about PPI. So again, this was something that was completely new to me as a novice researcher, something that I didn't have any appreciation of before I started the RM Partners Fellowship, but now would find absolutely essential to any grant that I was putting together and any piece of work that I will do in the future. We have 2 PPI representatives within our steering committee for the input study, which has been absolutely invaluable in getting feedback on things like our interview topic guides. They've also contributed to feedback on papers that we've written and contributed to the steering committee meetings themselves. One of our PPI representatives also took part in our video that we did, as well as trialling the interview topic guides. So a really important part of the whole research process, really. The time that I was afforded to do the research fellowship also allowed me the chance to expand my own network. So to build up a network of researchers, clinical academics and clinicians working in perhaps similar fields. So I was able to speak with other research dietitians, other researchers interested in palliative care, and really expand my knowledge of their work, but equally build up my own network of people that I can be working with and collaborating with in the future. Now, I've obviously touched very briefly on how the pandemic affected the study. Now, just with the timing of starting this study, I was 6 months into the study when all clinical trials were suspended. So I came back into my clinical post for 14 weeks from March 2020, which presented its own challenges. So obviously we had to put the study on hold for that time, which then meant reopening it. Also meant working through some of the feedback that I'd had from our own committee for clinical research when I came back to the fellowship again for the 3 days a week from the end of June 2020, which inevitably delayed some of that work that had been in progress, but completely unavoidable and completely unexpected. So it did have an impact on the running of the study, but we were able, because we'd postponed it, we were able to add those months onto the end of the study. So that time wasn't lost. I think one of the important challenges to highlight today is the recruitment around the study. Now, I think that was certainly impacted by the pandemic and working with some quite large centres. So UCLH and St George's, for example, trying to get our study through their own committees did take that bit more time because they had to prioritise COVID studies, understandably. And so there was a bit of a delay. By probably about 6 months, we were able to open to recruitment at the Marsden around 6 months earlier than we were at other centres. We also needed to extend the study multiple times because of this. We found that recruiting patients was difficult. It's a very niche group of patients. It's not large numbers of patients that fall into the criteria of people we were recruiting. So that did have an impact as well. And so we did extend the date, I think maybe 2 or 3 times. And so the study just finished as of last week. We closed recruitment. Next slide, please. So I thought it would also be really helpful to show you some of the outputs that have come out from this fellowship and from conducting the input study. So as I mentioned at the beginning, we obviously wanted to get an idea of what the field was looking like at the time that we were doing the study and putting together our research question and protocol. And so we decided that we would do a scoping review. That's going through some changes that have been fed back to us following peer review, but is awaiting its publication once we get those back. And that scoping review is around the experience, decision-making and information needs around parenteral nutrition among people with advanced cancer and their carers. So we looked a bit wider than just the information needs, which unsurprisingly we found there wasn't any dedicated studies to that. But we looked wider at what the experience was for the patient and the carer and what we already know about the decision-making process. As I mentioned, we also won a BRC grant to conduct or put together a recruitment film for carers, and that was with the input of PPI. I've also been very fortunate to present the study at various groups. Notably, one was the NCRI Cancer Nutrition and Physical Activity Workshop, which it was a real privilege to be invited to be able to discuss sort of research priorities in nutrition and cancer, and also to share with them a bit about what our work was. That was right at the beginning of the study, so it was really giving an idea of what we were going to be investigating. I also wrote quite a reflective article on lessons learned as an early career researcher, and specifically focused on the importance of working collaboratively within that article, and that was published in Dietetics Today, which would be one of our main British Dietetic Association publications. That is, dietitians, if we're part of that union, then we would receive that publication. We also had some abstracts accepted last summer, so to the NCRI Festival, and also to the Clinical Academic Training Office, which is at Imperial College, their research symposium last summer. We hadn't done the interviews at that stage, and so this was looking at what the methods were for the study. I also attended the Cato Starting Out in Research course myself, and then was asked the following year if I would be a case study for the next group of people attending the course the following year. And so I was able to put together a little bit about myself and sort of next steps that I'd taken in my research career to share with that next cohort for the course. I also very recently did a webinar for the British Dietetic Association Oncology Group, and that was around parenteral nutrition in advanced cancer, experience, decision-making and information needs. And in that, I was able to outline some of the findings from our scoping review and what we were doing with the input study. And that was nationwide, so that was open to all members of the oncology group in the British Dietetic Association, and we also had people attend that out with that group. We also intend to submit some abstracts this year. So we'll be submitting one for the British Dietetic Association Research Symposium. Hopefully we will also have one that goes to the British Association of Parenteral and Enteral Nutrition. And hopefully also NCRI will hope to go back and present some results. So one of the main parts of work for me now following on from the fellowship is to start to analyse all of the data we've gathered through the transcripts for the input study and write that for publication. Next slide, please. So for my next steps, I think the RM Partners Research Fellowship really was the starting building block almost as the way to think of it. So I knew doing this fellowship that it had given me a real flavour of what research was about, that it was something that I was really keen to pursue, and I would really like to continue to pursue a clinical academic career having done this fellowship. And so I applied to do an NIHR pre-doctoral fellowship, which I'm delighted that I was awarded and started in October of last year. So I will be doing that part-time over 2.5 years. As part of that, I've dedicated some time to wrap up the input study. So as I mentioned, we've now closed to recruitment, but I will then be doing the analysis and presenting at conference and writing for peer-reviewed journal. I'm also undertaking a postgraduate certificate in palliative care at King's College London's Cicely Saunders Institute and working closely with their team. So my primary academic supervisor is Dr. Sabrina Bajwa, who is a consultant in palliative care at King's College and a lecturer at Cicely Saunders Institute. So I'm working alongside them, able to attend their workshops and building up my work in collaborations with their team as experts in palliative care, and hoping to work with some of the team there on a systematic review. And the next steps on that will be to look at the healthcare professionals aspect of tying in with what we've learned from the input study and how healthcare professionals impact on decision making and what things might influence them. And another really important output from my pre-doctoral fellowship will be to start to develop a PhD proposal. So you can see that the RM Partners Research Fellowship really got the ball started to roll and really gave me that drive to be able to pursue a clinical academic career. Next slide. Thanks, Anna. And that's what I really wanted to share with you today. I'm very open to any questions, but I appreciate that's a little bit of a whistle-stop tour of starting the RM Partners Fellowship and where that has now taken me to at this stage. Thank you very much.
Thank you very much. That was great, Jennifer. And congratulations on the pre-doctoral fellowship. And obviously we look forward to seeing some of the data, the results coming out of the input study. That will be really interesting. I'm just wondering whether we have anything on the chat line. No? But I'm sure this is going to come up in the conversations after. We just got, I think, one question from Mick Peake. Mick?
After an excellent talk, really wonderful to see. I just wondered, are you aware how many people of your sort in the dietitian world are actually involved in any academic work? Is it really uncommon, or is there a cohort of you advocates out there?
We're out there.
Yeah.
So we're looking, I would say quite a number of us are looking at different things. So there are definitely clinical academic dietitians working within universities. Some that I'm aware of and have built up some links with through doing the fellowship. Within the Marsden, we've also have Dr. Claire Shaw, so she will be speaking to you shortly. So she leads our therapies research and takes, leads research herself. Next in line to speak is actually Victoria Nelson, who is also a dietitian by background, who has done an RM Partners Fellowship and a pre-doctoral fellowship as well. So we do exist. And we look at different things. So one of the contacts that I have looks at renal dietetics. There's people doing, different fellowships depending on their areas of interest. But it's not always it's not the most common. I would say most people work in clinical practice, but there are some.
Good to hear. Thank you.
All right. Well, that sounds like the perfect introduction for our next speaker. Thanks very much, Jennifer. That was great. So Victoria Nelson is our next speaker. Victoria is also a dietitian by background, and she's been working on a feasibility study for diet and exercise intervention for those living with and beyond colorectal cancer. Obviously, a lot of people in that situation. So, Victoria, look forward to what you have to say.
Hi, everyone, and thank you for inviting me to speak today. So obviously I'll be talking about my research journey that brought me to this feasibility study first. Sorry, could I have the next slide, please? So it all started back in 2018 when I got accepted onto the RM Partners Research Fellowship. I did this over 15 months part-time alongside my clinical role. The main output from this was a systematic review. So at the start of the fellowship, I started a literature review looking at papers, obviously looking at people that have been diagnosed with colorectal cancer and any studies that looked at diet. And I'll be talking about the results of that a bit later. Through the RM Partners Fellowship, I then, from the preliminary results of the systematic review, I decided to do a feasibility study and started the paperwork to get that going. But it became quite apparent that I wouldn't be able to finish that in the 15 months. So I also started an NIHR pre-doctoral fellowship application. Could I have the next slide, please? I was awarded that in August 2019 and obviously started in October and I finished September just gone. And the main output from that was finishing the feasibility study and I have some other outputs which I talk about a bit later, and the feasibility study just got published in February. I'll talk about it in more detail. Sorry, next slide. So a brief timeline of the last, few years. So I started out with the systematic review protocol. So the main reason we decided to do this was obviously that more and more people are living with and beyond cancer, so survival rates are increasing. And we know that lifestyle has a massive impact on primary prevention, but what about secondary prevention? So those that are living with colorectal cancer, can we put in the lifestyle factors that we would say to prevent cancer reoccurring? So it's just for those that don't know, some basics are a higher fibre diet, more fruits and vegetables, less sugar, less processed meats, less red meat, physical activity, less fast food, than the main ones. So that's where we started the protocol. Then we went on to do systematic review. And then the preliminary findings of that I took to a PPI group. And then we got some patient representatives from that, along with some academics, and started a steering group. And then in the steering group committee, we developed the questions for the feasibility protocol, which then went to ethics, and then R&D approval, and then I could start recruiting. But obviously through the recruitment process, COVID hit, and there was a lot of amendments, which made the methodology go more remote. It was already half remote, but it all went to telephone follow-up. And then we did the feasibility and finished it, which is great. Next slide, please. So just going back to the systematic review, the main findings. So I only looked at RCTs, so I only identified 7, of which 6 were finished and 1 was a protocol. The main problem when we did the review was that they all looked at different measurements. So only 3 looked at anthropometrics, so like weight, BMI, waist circumference. All 6 looked at dietary components, but they all looked at different dietary components. So some would look at fibre, some would look at fat, all very different and not comparable necessarily. Only 2 looked at quality of life. And then when you look further into the studies, the RCTs, the quality it varied. So some had very limited behaviour change in it. One even used patients that had previously had cancer to give the advice to other patients. So the level of expertise was a little bit questionable with the advice as well. And some just got handouts. So yeah, I've kind of covered the PPI development. So next slide, sorry. So from that, we made the feasibility study. So our primary aim was to evaluate whether patients who had undergone colorectal cancer treatment were able to comply with using digital technology to help promote and track individual healthy lifestyles, diet and physical activity changes. Can I have the next slide, please? So this slide shows our kind of intervention. So obviously consent at the very beginning. Once participants had been consented in, they were asked to do a 3-day food diary via a program called MyFood24, which is an online food program. They just enter it and the program analyzes all the data and gives me a lovely output of the breakdown of the diet. And they were also asked to do a Godin questionnaire, which measures sort of like baseline activity, self-reported weight and step count. So before COVID, they were coming in for this, and when I was measuring weight and we were doing a face-to-face sort of initial consultation, and they were doing that again at the end point. But when COVID hit, the baseline and the endpoint went to telephone, and it all had to be self-reported a bit more. And questionnaires were emailed or posted out. Then the intervention started. So they had their initial consultation with myself, and they picked 2 lifestyle goals to concentrate on over the 2 months. So some of them chose to lose weight, some of them chose to increase fibre was a big one, because when we looked at their diets, a lot of them were only having anything from 2 to 8 grams of fibre a day, when the recommendation is 30 grams of fibre a day. And another big one was reducing sugar. Again, when we looked at the dietary analysis, some of them were having a lot more sugar than the recommended amounts. And I managed to tailor it to them, so I could talk to them about the output from their 3 days. So saying, like this, how much protein you have. This is how much protein we would generally recommend for you with your weight and your diagnosis and everything, and tailor the advice to them. So we had fortnightly telephone consultations, and we just chat on how they were getting on and keep them focused. And then at the end, they would report the end data, and they'd also fill out an evaluation form, which was really our main outcome, was to see if this was a feasible way to kind of see patients, what they thought of it, the timings, everything like that, and also a resource on dietitians, so myself. And then at the end, I'd signpost them on to further resources. Next slide, please. Sorry, next slide, please. Thanks. So the main findings, So I screened a lot of patients. There's a lot of patients at the Royal Marsden, and there were 78 eligible to approach, of which I approached 69. And from that 69, got 20 participants consenting to take part. They were eligible anytime from 2 weeks to a year after they received their last treatment, and they became ineligible if they had metastatic disease or reoccurrence. So we did lose a few eligible people along the way as well. But the main thing was that we did find this was a feasible way to deliver information, and the feedback from participants was that they found it really useful. A lot of them didn't know the advice and were kind of questioning why they hadn't been told it in their kind of usual treatment pathway. And a lot of them would want this advice to be put into their sort of the normal patient pathway. I found it very useful. From my point of view, time-wise, it did obviously take a bit more time, but using the food diary program saved a lot of time and gave some good tailored advice. Next slide, please. So just going to general the fellowships, I also managed to complete a postgrad certificate in research methods and design. I've attended behaviour change course at UCL, attended conferences, started peer reviewing papers for other journals and reviewing peer reviewing guidelines. I've written some articles for various magazines as well. And then I've also mentored other newbie or early careers researchers in the clinical academic training office at Imperial on their starting out in research course. The main opportunity, I guess, is that I sort of changed my career after this. So from doing the fellowships, I gained enough experience and left sort of the dietetic department and joined the Royal Marsden School, where I hope to kind of continue a bit more research, but obviously also have to learn how to teach. So that's a new challenge in itself. Next slide, please. So my experience overall of the fellowships is that it's challenging but rewarding. The main challenges have been recruiting as an early career researcher, especially as an allied health professional. I think it kind of isolates you a little bit more. Trying to get into clinics and like know the people you're meant to talk to within big hospitals is very challenging. Timeframes for completing projects and funding. I think a lot of other people have talked about this. Funding to secure time is really important. Otherwise, I have no idea how anyone writes it up. And rewards, obviously, producing your own work for the cancer population and diversifying my experiences beyond my clinical work has been fantastic. And then the last slide, that's it. Thank you.
Thanks, Victoria. That's great. Excellent. I've got a question. I'm not sure there's anything on the chat line. I guess healthy eating. Question, I suppose, is: do you think the people who found it acceptable, which was like what 2/3, I think, were predictable, the ones you'd expected, or were there people who really made changes in their eating that really they wouldn't have had they not had this opportunity?
Yeah, definitely. I really found it with like fiber was amazing. Just people I think everyone thinks that there's enough fiber in sort of like fruits and vegetables, and they're like, at the beginning they're always like, oh, but I have my five a day, and it's sort of like, okay, well, you need to add in your like beans, pulses, chickpeas, and no one really wants to eat those. So it's like really kind of like tailoring around how to get it into a normal diet and sort of saying the importance of it for especially colorectal cancer, where they really should be up at that recommended 30 grams a day. And I just don't think as a general population anyone's aware of the foods that actually are high in fiber.
Right, so that's okay. Mick Peaks has a question.
Yeah, thank you. I was interested in what your mix of cancer patients were in terms of what sorts of cancers they had, and whether you had any particular issues with those with GI cancers. In other words, were they easier to be engaged because they had things in their gut, if you like, at a simple level, or
yeah, so I only recruited those that had colorectal cancer, just stages 1 to 3. So if they were stage 4, they were excluded from this study.
How applicable do you think your work is for other cancers? Then is probably the better question.
I guess it would be so this would be applicable to sort of like breast or prostate, where there's a lot of large evidence around diet and lifestyle to the cancer population. So I guess any of those sort of cancers may be more like other cancers, the rarer ones that would need more kind of evidence around those ones, because it'd be a slightly different population. But yeah, definitely to breast, I think it would be similarly applicable, but again, completely different population.
Yeah.
So we'd need a different sort of study, maybe.
Thank you.
I think Arnie has a question. Arnie?
Thank you, Victoria. My question is, how do you adapt this to patients who might have gluten sensitivity or who are on a FODMAP diet?
So I guess that was the main crux of it, and why when I looked at my systematic review, no one in any of those studies was a dietitian, an oncology dietitian like myself, that was giving that tailored advice. So I guess that was sort of the main thing of the study, is that as a specialist oncology dietitian, very good experience to kind of give that tailored advice. And that was sort of it, is that a handout or a previous patient giving advice isn't enough. You do need one-to-one tailored advice, really, and that's what this program was. And it does essentially need to be an oncology dietitian to tailor that to the patient in front, because colorectal cancer patients are not, they're not simple. We had a lot of stoma reversal patients, a lot of high stoma outputs, a lot of like GI changes. So sometimes actually I wasn't giving sort of that healthy lifestyle advice. I was giving sort of like high stoma output or electrolyte advice, or quality of, how just to gain a bit of quality of life back for them to leave the house. Unfortunately, that wasn't captured in this study, but it's something I want to look more at the stoma population in the future.
Thank you.
Put myself back on. Victoria, I might have missed it. Apologies if I did, but the exercise component to yours, was there a target step count or something that you had in mind? And I think, sorry, go on.
No, not really. That was just more collected because it's a feasibility study. It's more collected just out of interest and to help them if they decided to try and increase their activity, which actually I think only one person did in the end. It was there to use as a baseline alongside the Godin questionnaire, just to see if they did make changes over that 2 months. But again, their step counts were quite low.
Is that going to be part of your ongoing interest? I mean, there is evidence, I guess, that it might make a difference to response to immunotherapy. I think there's some data on that, for instance.
Yeah, I mean, yeah, obviously, as I mentioned previously, like stomas and colorectal cancer, like dietary, lifestyle, and around quality of life. I know it all sounds a lot, but yeah, something kind of trying to bring in all those components would be the next step. But yeah.
Okay. Well, I think if there's no more, thanks very much, Victoria. We're going to move on to your mentor now, and obviously Claire Shaw is a consultant dietitian at the Royal Marsden. One thing I should just say, I think both you and Victoria had mentioned that the fellowships were Royal Marsden Partners Fellowships. They are, of course, Pan-London. We should say thank you very much to the other alliances for supporting these research fellowships. They are Pan-London. It's a critical part of the collaborations across London, and with that we can see that is the title for Claire to reflect on the springboard for research. So Claire, over to you.
Thank you very much, Stan, and thanks for the opportunity just to feedback really about these fellowships and how they've really provided an opportunity that we didn't have before. So next slide, please. To start with, I just wanted to touch on what my background is. I'm consultant dietitian at the Royal Marsden, and I undertook my PhD whilst I was a clinical dietitian and managing the dietetic department. And it took me far too long and was very arduous. So I'm absolutely delighted that we now have other career opportunities to open out to really get people on the ladder. And I think Jennifer and Vicky highlighted that to have that ring-fence time is quite unusual for AHPs and is absolutely invaluable to give them an opportunity to dip their toe into research. And that career pathway is not particularly well established for allied health professionals, so it really is an opportunity that we grasp if it's there. I have research as part of my job description. I'm the lead for therapy research, so I have an opportunity to support other allied health professionals within the Royal Marsden. So speech and language therapists, physiotherapists, occupational therapists, speech and language therapists, and of course dietitians. And in my work, I'll touch on it a little bit, but I am collaborating with other organisations that are focused on research, and that is a really great opportunity to bring people together. And a lot of my contacts, both within and outside the Royal Marsden, have supported both Victoria and Jennifer, and that has been really, really helpful, and has meant that we've been able to support different types of research that may or may not be my speciality, but with that network, they've had excellent support from elsewhere. So next slide, please. As I mentioned, I'm the lead for therapy research within the Marsden, and I'm also a member of the NIHR Cancer and Nutrition Collaboration. So this collaboration was set up nearly 10 years ago now. We have our own website, and the idea was very patient-led ideas about there isn't enough research into nutrition and cancer, and there are lots of unanswered questions about nutrition and cancer. So the NIHR collaboration is very much focused on bringing researchers together, encouraging collaboration, getting peer review on research protocols, and it also has a number of strands which are very outward facing, looking at providing good evidence-based information for patients and carers about nutrition and cancer. And our Biomedical Research Centre has embraced that and supported me to work both with our BRC to embed more nutrition and cancer research in our own portfolio, and to network and undertake research with other organisations who have this as a priority. Next slide, please. So the NIHR Cancer and Nutrition Collaboration has its own website, and this is an example of some of the work we did back in 2019, which was in collaboration with the Royal College of Anaesthetists and Macmillan to produce guidance on prehabilitation, and this resulted in an NIHR call for research grants in prehabilitation. So it's also about influencing the landscape and using that to feed into some of the projects and ideas that we might have ongoing. Next slide, please. So just to come back to, yes, that's great. Just to come back to that lead for therapy research, just to say that all the applications we've put into the RM Partners / Pan London Research Fellowships have all really focused on topics that have been clinically relevant, and we've looked to things like the James Lind Alliance to really shape and influence the research questions that we've developed. And I have written a research strategy on nutrition and cancer for our own BRC, and we've used those ideas to underpin the applications that we've put in. Next slide, please. So my experience of the Pan London Research Fellowships really, as I said, a fantastic opportunity for allied health professionals that we don't always get. So we've had 2 submissions funded, and the title of Victoria's was actually broader when it first went in. And Jennifer alluded to the fact that once she was awarded the fellowship, we had to go back to the drawing board and refine the questions. So I'll talk a little bit about that. I'm also co-supervising another research fellow in collaboration with Imperial, and that's Ria Sagu. I think she might be on the call today. Slightly different topics. Ria's is about prehabilitation in women with ovarian cancer, but again, an ideal opportunity. And I think with all these research fellowships, it is about the project, but it's also about the person. And any of you that have been awarded them know it's that combination of the two. So I feel it's very important that once somebody is on that fellowship, that they have an investment in them as a potential researcher, really to develop that interest and give them opportunities. You know, so if they do want to step on the NIHR clinical fellowship ladder, which both Victoria and Jennifer have done, it's an ideal opportunity for them to decide whether that's a career pathway they'd like to take. So next slide, please. So I've just come up with a few tips from my experience. I did mention that I've really pulled on my contacts and collaborations both within the Royal Marsden and the BRC and outside. So having a steering group, or in the case of Victoria, we had a good strong collaboration with Amanda Cross from Imperial, which really underpinned good ways of working and was invaluable in shaping the research and producing the paper. I've also drawn on my contacts in the NIHR Cancer and Nutrition Collaboration, and for Jennifer's work, she has a steering committee that includes key people from the collaboration to help guide the research. And also we work with a qualitative researcher who was based at Southampton, who's helping with the analysis of the work. The projects have also got strong PPIE, and we've also had additional funding from the BRC, which again has proved invaluable. And that's something in the future that I think we really need to strengthen and use different methods for engaging with patients and carers. My word of warning to other people, don't be over ambitious. We do want to be ambitious, but with both projects, we had to pare them back. And I think what can be achieved in the time scale with early career researchers who, you know, are learning the ropes and taking a time to get to grips with the process as well as the content and the subject. So both projects have had to have been pared back, and both had to carry on during the NIHR pre-doctoral fellowship, which was invaluable because it's enabled those projects to carry on to fruition, which they might not have been able to otherwise. As I mentioned earlier, investing time in the research fellowship. So for both the fellows, we have very regular supervision and catch-up sessions, and within the Royal Marsden we also have a network to support pre-doctoral researchers, which again the candidates have tapped into, which has been fantastic. So we have support within the organisation and the BRC, and we've used that support to help really you know, get these projects, keep them moving. And I think the other thing, I know I've said I've been over ambitious, but the expectation is absolutely that these projects will go through to peer review publication, and that's been discussed right from the beginning. And with Victoria's work, we were particularly pleased because it's been accepted for a special edition of the Journal of Human Nutrition and Dietetics. So that's a great opportunity and showcase. And with these candidates going on to do their NIHR pre-doctoral fellowship, we want really good, concrete, peer-reviewed publications that they can include on their CV that will provide this strong, robust springboard for whatever they want to do next in their research career. So next slide, please. So thank you for listening. I'm happy to answer any questions or listen to any comments. So thank you very much.
Thank you very much, Claire. That's great. That's just what we wanted to hear. I think just wanted to emphasize to people on the call that this is a really important thing for the Pan London Fellowships. Half of the fellowships that we award are to AHPs, and dietitians obviously are key. We've awarded fellowships to physiotherapists, to psychologists, to nurses, to pharmacists, and it may be that population finds it harder to access research funding sometimes than clinicians. So please, those on the call, remember that, because we will continue to award at least half of our fellowships to AHPs. And in the conversations, Claire, by all means, join the panel discussion. I think that one of the questions I was going to ask a bit later is that how you define an AHP and whether we're missing any. It's a rather sort of nondescript term, allied health professional. So maybe some professionals who might feel disenfranchised. I don't think there are, but if there are, you need to look at that. I think there is a specific AHP organisation, unless I'm...
There is, Dan, yes, there's the HCPC. So that's our registration body. I suppose, you know, of the professions you mentioned, radiographers, have you ever awarded to radiographers?
Yeah, our first one this afternoon was a radiographer. Well, an ultrasonographer, I think.
Yes. Yes, I think it probably does. Yes. So yes, I think we probably just need to make sure that they are all captured.
I've got a question for you from somebody on the panel. How have the alliances been able to support the implementation of the research findings into clinical practice? If it hasn't, what do we need to do to put in place to support this? So to support the implementation of research findings. It's always a question that's hard to answer. But
really good one. So Victoria's work, particularly the feasibility study looking at a dietary intervention, that has been a catalyst for us to have meetings across some of the organisations we've mentioned today, so the Royal Marsden and Imperial in particular. And so this isn't really about implementation. I suppose it's about a springboard to could this follow on with more research. And we have talked about linking up with expertise from other BRCs, particularly Imperial, to see if we could do a slightly different study looking at an intervention study. So that's not really answering the question. So I suppose that is a little bit of a gap at the moment. I think it's a bit chicken and egg. Certainly Victoria's work, very important that we consider the dietary interventions that may influence outcomes, but at the moment the evidence base is not quite as strong as for some other diagnostic groups. So I think there is a slight hesitation about implementing it in practice too wholeheartedly when actually the evidence base is slim. So I don't know about any of the other studies that have been mentioned today.
Well, implementation is a key issue.
Yeah,
I wasn't sure whether there was a question there. Was it from Mick or this has gone down?
Well, I was just wondering whether to do it here or in the panel discussion, but I think the interaction feedback with the alliance is crucial. I mean, they are the largest funder along with BRCs, and if we don't address their requirements, needs, and strategies in any way, that's going to affect our long-term relationship and income apart from anything else. So I do think how we feed back to them and how we try and define how what we're learning could impact on what they're doing, quality improvement, etc. I think that connection is really key and one we perhaps haven't explored as much as we should have done.
Yeah. Okay. I think we could probably move to the panel discussion. Arnie, before we do that, Arnie's got a question.
So it's linked to the earlier point, Stan, and that is about the dissemination of the results. I mean, clearly colleagues are publishing and there is a global audience that's looking at these results, but the diffusion and adoption curve is often very slow here. But what can we do within our gift to disseminate these results widely across our communities in cancer, not just in London, but across the UK?
Indeed. Well, that's a question. I don't know whether we should discuss that. We'll bring that part. One of the questions I want to address in the panel discussion a bit is the direction of travel of the research fellowships, and something to do with implementation might be something we should cover in that context. So let's move to the panel discussion. And Claire, you're welcome to keep on the line, and other speakers who are able to, please do. I just wanted to say one thing first. That is that we're planning the programme to continue. We have funding to go forward, and we'll be starting the ball rolling in a few weeks' time. We just need to finalise the details of that with our funders, the alliances and the BRCs, but we expect to be able to launch that in the coming weeks, and so please watch out for that. Now, I'm just looking back over the 6 years we've been doing this, and we have increasingly wanted to reflect priorities for what we think the fellowships the areas that they may want to focus on. But that's a matter of opinion. We've done that through the steering group, which meets regularly, and we'll be meeting again. But I suppose one of the key outputs I'd like to get from this final session are thoughts from the panelists and others about what they feel we should make sure that we, as best we can, direct the fellowships towards. We can, when we put the call out, we can be quite specific. Last time we were relatively non-specific, but we talked about wanting to look at the areas of inequalities and personalised care. Previous time we'd focused on early diagnosis, but I'm just wanting to make sure we're not missing anything, and maybe aspects of implementation might be something to fix on. But does anyone want to lead off on that? What do we feel the fellowship programme 2023, as well as making sure that we appeal as much as we can to AHPs, are there specific areas that we should highlight in our next call? Mick has first go.
Sorry, I think the two main areas for me are early detection. I want to get Tom involved in a debate about the future now with the changes in general practice and all the digital things. But the other one is the fact that certainly in my own field in lung cancer, we've now got a cohort of advanced disease patients who are living a lot longer, and how we follow those patients, how we detect early recurrence, how we deal with the complexity of the support that they need, both in secondary and primary care. That is an area that's getting bigger. Speaking to my friends in oncology and lung cancer, their clinics are totally full now of follow-up people on targeted immunotherapies who are living 2, 3, 4 and more years. And how we really don't have the policies or the evidence to know what the best follow-up and who does that when and where, and how we detect early recurrence, and it's a sort of early detection story there. But the other main area is the one I first said about how we adapt to the changes that COVID and digital working and the workforce issue in primary care. All the work I led at DH on public awareness, for example, was dependent on easy access to primary care. A lot of it was. And so that's really awkward. So my own view is those would be the two priority areas I would push. It's personal view.
Tom, did you want to come back on that?
Shall I come back a little bit, Mick? Thank you. Yes, absolutely an issue with access to primary care. Looking at the sort of policy stuff going forward, we're going to be looking at self-referral, I think. It's got some of the options, and you might have heard about the pharmacy upskilling project. Like everything, that will need to be evaluated and look at the evidence base and the costings, but we've got an ever-decreasing GP workforce, so we're masters of everything and not very much at the moment being put on by everybody. So I really think actually moving to larger primary care at scale, but also enabling routes to triage testing and self-referral, I think will be really important. I think we have to push the policymakers on that, but also getting the evidence base. So coming back to Stan's question really about where do we focus? Well, I think obviously you want the right people, and actually thinking about people who maybe don't get an opportunity so easily with standard out of sort of training. So it's really good that we do half as allied healthcare professionals, because they might not always get the opportunities that medics get. I think that's really key. And also, I see this funding really, and to coming to Arnie's point about sort of, we're kind of in that sort of translational NIHR piece about actually, can we demonstrate impact within 3 to 5 years of this work? And I think all the projects today really have demonstrated that they're making impact or will make impact within that time frame.
Thanks very much, Tom. I think that's really important. I just wanted to say the other thing is that when we go forward, we absolutely will be in dialogue with the alliances who are funding the fellowship programs to make sure that whatever we do is in line with what they want to see as priorities. And I'm sure that what you've just said, making sure that what's being done is going to make an impact over 3 to 5 years, I would imagine would chime with the alliances, but we'll really want to make sure that we've got that dialogue so that the funding is going in the right direction. Arnie, next.
Two thoughts, Stan. I just want to ask Tom a question, just so I've understood it. Tom, when you talk about self-referral, enabling routes to testing and self-referral, do you mean that the person will not see a GP, but will be able to access diagnostics as a result? That's my first question, and then I have a comment.
Yes, so Mick nicely talked about, and colleagues in Leeds did a project where patients could self-refer for chest x-ray, and they did so a stage shift. So you've got to think about what is the test, what is the safety, so chest x-ray safe test. So I think the key people getting involved is the radiology colleagues, because they always think that they're going to open the floodgates. It's the same actually issue for access to CT. You know, GPs, I can't access CT easy. So I think that's a key piece, getting a sort of whole system approach. Also, I think, you know, why couldn't patients, you know, fulfilling certain criteria self-refer for a FIT test, as an example? If you've got rectal bleeding, certain criteria, you have a web-based tool or something. I think that's the direction of travel, but we need a lot more research in this area, both health services research and implementation research.
And just a follow-on question on that, if I may, Tom, is there an appetite in the community in primary care for this to happen?
This is such a really interesting question, considering I gave that lecture last week to hundreds of GPs. There was a little bit of resistance in the room, but I think most were saying actually self-referral probably is a good thing. There's a concern about over-testing and over-diagnosis, though I think actually if you look at international comparisons, I don't think we're at that curve yet. You could argue, yes, like America and other countries, you'll pick up false positives, but I think actually all the research shows we probably need to do more testing and more diagnostics.
Thanks. Stan, I just want to come back on Mick's point about early detection. So I personally think that needs to be a priority, given that COVID has undone some of the good work that was done previously. We know now very clearly that there's a shift in stage of diagnosis in many cancers as a result of COVID. We're all seeing it in lung, prostate, breast, head and neck, and colorectal cancer are good examples of this. So it's going to take us a while to redress that. But in the meantime, I think research projects that can put in ideas that can effectively ramp that up to get it back to where it was, or even better, might be helpful to think about.
And the other issue, of course, that a lot of the interventions that you do feed what Tom mentioned, the inverse care law. So and we know that deprivation has got broader, or at least access has got less equal over COVID for lots of reasons. So I think building in how you make sure that whatever techniques, open access to various things, how they are facilitated in the deprived and less engaged groups is a key part of any research in this field as well.
Theo, I think you wanted to come in on that.
Yes, I mean, just on kind of self-referral pathways, I think with FIT, patients increasingly have FIT advertised privately. So private companies will do a FIT test for them. So it's available to them. And what they then may do, and I've spoken to patients who've done this, is then go with that result to their GP and say, right, I've done this. And so what are we going to do? So I think having a structure that allows self-referral for FIT is actually quite a good idea, because it's something that's already happening anyway.
Right.
probably it's highlighting inequalities because it's your educated, tech-savvy patients with a bit of money that are paying for it. So actually, you know, all these things, as Mick rightly says, that we exacerbate inverse care law somewhat. So I think I'm very keen that we keep inequalities and making sure whatever we do, we assess to try and reduce inequalities as much as possible as a common thread throughout all the pieces of work that we think about doing.
Yes, yeah. I agree.
Got a couple of things on the chat line that I just want to raise. So before we do that, Arne, did you want to make a comment on that?
No, not on that. I'll come back later. You go ahead with the chat.
Sandra Dyer has said areas to consider in the next call include primary care and personalised care, which is obviously true. For example, evaluating quality of cancer care reviews and multimorbidity reviews. And then she says, consider how to reach the wider primary care workforce, nurses and AHPs, reduced opportunities for these groups. So I suppose it may be a question for Claire in a way as to how we talked about that we want to do that, how to reach this wider primary care workforce. Maybe Tom or Claire might want to comment on that.
Claire, do you want to go first? And then I
Yes, I will. I was just trying to turn my camera on. So, yes, I was thinking about that after Sandra typed it, actually. I think, certainly from my perspective, I think you either need, well, you need somebody to lead those. So my question would be, do we have senior or research savvy AHPs in primary care or in organisations? I can see Tom's nodding, to lead those projects, or we need them to be led by doctors or nurses, but recognising that AHPs have certain particular qualities. So, you know, we've talked earlier on, haven't we, about the project and the person. I would say maybe we need a bit more of a forum to try and identify where we think these people are, and try and encourage them to think about projects. But, you know, I'm in a fortunate position that I do have research as part of my remit, and I'm an AHP. But I wouldn't know how many people there are like that across the patch. I know there are pockets of very strong, I know Imperial particularly, and the Marsden, we are very strong on AHPs who are doing research. But I wouldn't know about that in primary care. But I think that would be an ideal opportunity.
Yeah, Tom?
Yeah, I would say very limited. Most, obviously there's pressure for the clinical work, and we do have a lot of nurses who are expanding out with masters and then and becoming independent prescribers. So actually a lot of it's about medical education, so about sort of upskilling and teaching and diagnosis. We've got an increasing workforce coming on, which will come on tap shortly, which will be the patient assistant type role, physician's associate type roles. So where do they fit in as well? And also clinical pharmacists and these primary care networks. So there's a lot of investment, hopefully investment going in expanding the primary care workforce, but I think there's a lack of and most of it's service delivery. So I do think there's a piece of work about getting people together about how we could think about people who are keen to follow a sort of twin track research career. It's definitely more difficult in primary care. We don't get any backfill funding, so everything has to either cover the clinical work or you're covering a locum. So and obviously each practice is run either by partners or in a larger organization, which is independent contraction model to the NHS, which does make things a little bit more complicated.
Yeah, I'm sure that's true. Arne, let's come back to you.
Yeah, thanks. So we now have an NHS digital strategy that was launched, I think, a couple of years ago. I think it'll be good to consider looking at digital health and the way we use technology to deliver healthcare or research projects in this area. And that could maybe also bring up issues of inequalities in accessing digital health technology, not just among certain ethnic groups, but also certain older age population, cancer patients or people with cancer at an older age.
Right. That's a good point. Mick?
The other opportunity or threat, whichever way you see it, is the way that the Cancer Alliances and the ICBs, the ICSs are altering. And the ICB, potentially, the integrated care boards may well provide an opportunity for better links between primary and social care, which could be a research space, collaborative research space, which we haven't really explored properly or had the opportunity. So I don't know, depends how they evolve, but I think we need to be very aware, particularly in London, well, we're talking about London here, how each of the ICBs is evolving, talk to them about how this sort of work can influence their commissioning and practices.
Yes, I mean, presumably implementation will be key to that. So I guess it's partly, Michelle put a question which you may have seen there. Can the panel discuss in more detail what types of collaborations they're looking for? I mean, could that incorporate industry, for instance, which hasn't been a major feature of the fellowship applications, at least initially. I mean, it can spin off into that. Are there any areas of collaboration that I don't know whether there's some that we're not properly exploiting? I mean, the collaboration with other groups. I mean, Tom knows that we're talking to CTST in terms of making sure that we're capturing within London all the interactions that we can, and that will be very important for primary care. But Mick, you may have a...
Yeah, I'm sorry to keep talking too much, but I have run until very recently the UK Lung Cancer Coalition, and we've developed a very positive and a non-promotional relationship with one or two industry partners. You may be aware that MSD funded a big public awareness initiative in lung cancer as a result of COVID. AstraZeneca have done a lot of work on improving information to the public on lung cancer screening and the lung health checks. I think there is an appetite out there among some of the industry partners to do health services support work and quality improvement. And I don't see any problem at all if that's done in a proper way. So I think that may well be another source of income and support.
Yeah, absolutely. Okay, we have run into other questions that I'd raised before, but I want to make sure we're not missing anything else on the chat line. So I think one of the things...
Could I come in just on Michelle's questions then?
Yes, please.
Yeah, just a little bit. I mean, obviously, collaborations are difficult. That's the first thing you've got to manage, especially Mick's nodding slightly, especially if you're doing sort of across pan-London collaborations. It can be quite tricky, you talk about sort of funding, finance, timing, where does the grant live? But I'm very keen that we do more of this because actually, breaking down barriers, particularly primary and secondary care, but also with different specialties that we've got on the call today. Really, you get more value added for your research and your implementation. And then industry, yes, but I think it is tricky around we're collaborating a little bit with some third sector and industry organizations, mainly on new technologies. And I think that's, evolving in new technologies. That's a key area. I think Arnie's put a grant in. Maybe there was a recent call out using digital technology. So there's a lot of growth in looking at using big data. How do we link up primary, secondary care data, etc., which is very difficult and complex to do. But in the future, how we could utilize, we talk about AI, but actually machine learning or other techniques, augmented decision making with companies in this area.
Yeah, I wonder whether that might help us use. I mean, there's a huge amount of data within London, and with the inequalities gender. I was just struck, Tom, with your earlier conclusion, correlating the deprivation of the practice or the area that the practice was in with the outcomes. And that, I guess, is what you might have expected, but how to deal with that and how to use London data to make a real contribution. I don't know whether you have any comments on that. It just seemed to me such a key area.
It's so challenging, isn't it? Michael Marmot, you'll know his work, I'm sure. We had a great talk from him last week. It was actually quite sad in a way because we've known about this for, his first report was 10 years or more ago. Julian Tudor-Hart, who is one of my heroes, if you don't know his work, please just have a quick look at his work. He wrote the inverse care law in the Lancet in 1971 as a GP working in the Welsh mining villages, as an independent GP interested in research, and showed that his population who were the most deprived actually had the least healthcare spending, and that has been 50 years or more continuing. What the saddest part was actually the government has refused to speak to him. sorry to be a slight downer. So actually the Tory Conservative government will not speak to Michael Marmot or anyone who's doing any of his work at UCL, which is very difficult because we do need a new funding model to take into account deprivation. My deprived patients die 10 years younger. You know, they get the multimorbidity 10 years younger. Yet if I was working in a rich area, I would get more funding per head of population. Just doesn't make any sense. But I think we just have to keep pushing at the whatever doors we can, that we need more evidence-based models around addressing some of these health inequalities.
Yeah, absolutely. Well, it just seems to me that if we're really pan-London, and we are, the contrasts across London are so sharp. If an alliance structure can help contribute to this area, then we should. But it's easier said than done. But sure that it's uppermost in your mind, Tom.
Yes. Well, a nice little. If I had the tube map going across to going from your patches in Chelsea, going across central London, it's one year of life for every stop on the Jubilee line.
I know. Well, I mean, for people on the call, we've insisted that the fellowships involve at least 2 alliances. We can't expect all the alliances to work together all the time, but we do demand an element of cross-alliance interaction. Otherwise, we're missing a trick. But Arnie, I think it's your turn.
2 points, if I may. The Mayor's Office is very interested in inequalities. Is that an organisation that we should consider working with? My second point comes back to Tom's earlier point about inequality. So we know social determinants of health, looking at social, cultural, environmental, and political reasons for health and disease as such. And is that under that broad umbrella, are there areas of research that we can do for people with cancer in London? There may be opportunities there. So just putting that out there as a potential area for research in the future.
Absolutely. Thank you. We had 1 or 2 other points. Oh, sorry, Mick, you go first.
Well, no, if you deal with the chat ones first, Stan.
Well, these are not so much in the chat. These are points that we just wanted to pick up in case they've not been picked up before. But why don't you go first, Mick, and then I'll
just
come
say 2 things. Firstly, I think, particularly with regard to nurses and AHPs, what's clearly happening to some extent is a network of or mentors and people who are gaining experience in this field across London, and that is probably a resource we should advertise and build on, because getting somebody to support these early researchers, particularly outside of medicine, is really key. So that may be one of the outputs. But the other thing is that, I don't know if you know, but One London is interested in improving the collection of data or the collation and linkage of data across pathways of care. And we've just got a grant from them to do that, which is called the Pathfinder program. It's limited in time, but its aspiration is to link data across pathways of care, including primary and other sources of care. And I think that may, over the next year or 2, really become a very powerful source of data and also quality improvement initiatives. So it's worth talking, I think, to One London about their informatics aspirations and achievements.
Perhaps if you could let us know the link. I'm not sure that we've got that link, but if you could let Michelle know, that would be great. I think, Arnie, you want to come back on that? Or was that? That was.
Sorry, that's Legacy Hands. Sorry.
Hand. One thing I was going to ask, it was interesting in Claire might comment that I think a key thing for these fellowships is what happens next to people. Tom's a perfect example of a recipient of peer-reviewed funding following we can only offer 12 months funding, and we're not going to change that. But what is so good to see are people who have gone on to, let's say, an NIHR fellowship and gone on and they've moved out, and we've got some examples of that. Are we missing a trick? I mean, in terms of is there something extra we should be doing to try and help people with the next step? I mean, maybe they're well enough advertised, but I just want to make sure that we're giving people the right advice. And it's interesting that the dietitians obviously know the NIHR structure. Any structures that we should be making sure we maximise the use of Mick?
Just the simple fact that we've seen it again and again today, what people have been able to do, where they have been able to get funding, what sort of support they've got, attempting to quantify and characterize how people have done that in the fellowship program, and giving those who are applying and who will succeed in getting future fellowships that experience and learning on its own would be useful, would it not?
Yeah, I think we need to document that properly. I think we've got data on that, but of course people can do 12 months over 2 years, 6 months, and that's an option as well, but that's an individual thing. It is still only 12 months funding. Tom?
I'd agree, Stan. So the flexibility was great. So, I had the flexibility and I spent some of it, but then I got the NHR, and then I was able, actually, with discussion with yourself, to expand out some of the projects. So we already had ethical approval. So I didn't really go into that in detail, that we expanded out lung cancer qualitative study, and we've got a systematic qualitative systematic review in that area as well, which will be coming into publication. Then obviously gone on to get more grants and have a portfolio career. So that's been a real springboard for me. And I'm a big fan of pump priming people and the projects and the place, isn't it? It's all three really, making sure they've got the right supervision, the right person at the right time, with a good sort of project to get going. So I've done a little bit of research before, but I found that a really good flexible opportunity for me to continue doing part-time clinical work and part-time research. I guess then I sit on another funding panel, and we do look at we find actually when we've looked at these, that the pump priming sort of fellowships, or initial 1 or 2 years, they're very cost effective in general. So I think if we could have some further metrics, and even think about, we had lots of applicants and we only had a small pot of money, even thinking about could we try and expand out even more, because I think there, especially in under AHPs or under funded areas, maybe we could have a look at.
So AHPs are underfunded areas. So.
Oh, no, I meant like people who don't classically get these opportunities. So yeah. I was saying, actually, I was being slightly biased to saying people in hospital medicine probably get a bit more opportunity, like Wellcome, MRC. Yes. They don't rarely fund GPs, I have to say. So we're much more the NIHR health services end. So, and the NIHR programs are good, but the success rate, you're looking for the fellowship, the doctoral fellowships, I think is around 15% success rate getting them. So it is difficult. You want to give yourself the best shot. So having that mentoring, supervision, practice, using your sort of pump priming fellowship to get initial data publications that give you the best shot to get to go through.
Okay, that's great. Thanks. Claire, you've got a comment on that?
Yes, absolutely agree with Tom's comment about that. The pump priming. I just wondered, is the information on what people have done and where they've got additional funding from collectively across these fellowships, is that information available to be shared, just to give people ideas as to what others have done and where they've been successful?
Yeah. Michelle, we can put that together. I'm sure
that would be useful.
It's been put in slightly different forms, but we could do that. I think that will be quite an easy thing to do over the last 6 years.
And that in itself, Stan, might create some connections with ideas and things that, there's a bit of an alumni now, isn't there, of people who've been through the fellowships, and maybe some of the ideas that there could be some sort of cross-fertilization between people and organisations.
Absolutely.
Yeah.
Mick, you want to add to that?
Just on a slightly different topic, I was struck by something that Theo said about how he'd gone from being a surgical trainee and understanding the technical side and the medical side, but how he came to understand how to change things within the NHS and how you implement something in practice. And I don't think very many academic doctors, if they're not actually directly in health services research, understand how their maybe ivory tower work actually is going to work in practice. So I think that the learning for the medics coming into this sort of program is really key. And I think that's something that should be both cherished and understood and nurtured, perhaps.
Absolutely. There's just a message come in from Darylyn Hughes. Darylyn, apologies because your chat function has only just become enabled, and I'm sorry that you've not been able to put it in before, but thank you for thinking that this was a great meeting, and Pathfinders are going to put out a new set of calls this year. Also, North Thames NIHR has just put out a call for projects addressing inequalities, so that's good to know. Excellent. So I guess just thinking ahead to our next steering group meeting, people might know that people on the call are part of the steering group, and I'm keen that we make sure we have the right feedback for that next meeting in terms of guidance for the next topics. I think that we'll obviously have the dialogue with the alliances. Access to primary care, I think, is a key thing, and I think Mick pointed that out. And in terms of early detection of recurrence, I think that's something that we're going to need to come back to. I think that's certainly an area that's I think is a very important one. Access to GPs. Did I hear that we should be interested in projects looking at self-referral? That might be something that we've not really done before, but that might be quite interesting. If there's a context in London that can address that, that would be fine. And I think Arnie's point on digital health is key. That there are projects there. There's a resource that we could be using that might really help us address inequalities, which I think we're going to come back to as a key theme. There's so many different facets to inequalities. It would be churlish to think that wouldn't be included. And we really want to see AHPs coming forward in that area if we can, including those AHPs attached to general practices. Sorry, did you want to add anything to that, Tom? You looked as if you were about to say something.
We had that reflection, didn't we, Stan, a couple of weeks ago? Pre-COVID, Mick was there. We had a really good meeting, which was a Pan-London meeting looking about research and implementation, trying to get everyone in the room who are not all normally in the room. So that's kind of GPs, secondary care, public health, policymakers, PPI, patient representatives. So I think actually, we're sort of reflecting where we've been. We're coming through the pandemic. I think it would be a really great opportunity. We discussed maybe in the new year to have sort of a workshop type event where we get people to present the findings and we think about next steps, implementation, but also next pieces of research, and actually bringing people together a little bit would be fantastic.
Yeah, good. Mick, do you want to follow up on that?
No, just to say that I think had we not had the pandemic and other things, we would probably be a lot further on. But I think we were beginning to form relationships. We were beginning to see relationships forming between the institutions and across disciplines that have been helped by the fellowship. So what the Pan-London Alliance really wants to do is go, I think, beyond just the fellowships. It's trying to stimulate collaborative groups to work together on some of these issues beyond the fellowships as well. So I would very much endorse what Tom says, particularly the links between primary and secondary care, and between the medical and the AHP communities.
And across London, yeah, absolutely.
Yes.
Just coming back to Derlin's point, Derlin, I'm sorry you can't join the conversation, but thanks a lot for your comment. And if there's information on that call that North Thames NIHR put out for projects addressing inequalities, it would be great to see that, and we could talk about that at the next meeting. Okay, well, we're doing pretty well. I think that thanks, Derlin. Did we have any other points? I think we've covered the ones that we thought ahead of the meeting we'd like to cover. And we've had lots of interesting discussion. I'd like to, at that point, I think, hand over to Arnie. I don't know, Arnie, we didn't expect you to be talking for half an hour, but we'd be really grateful if you could make some closing remarks. This has been, I think, for me, a bit of an experiment. We haven't done this before. I think it's been quite reflective that we've been able to look back at the fellowships. But Arnie, I'll give you almost the last word.
Thank you, Stan. I think the right word is reflective. I think I've thoroughly enjoyed it. The talks have been great, and the science has been really good. The discussion has been fruitful and wide-ranging. And it's helped us think about our next steering group meeting in terms of the way forward. I simply would like to thank the 33 fellows who have seen us through or seen their projects through, the 7 colleagues who presented today. It was excellent. Members of the panel, the selection panel, members of the steering group, and a very special thanks to you and Michelle for steering us through this entire program over the last few years. I've no doubt in my own mind that the years forthcoming are going to be an equal, if not more of a success. Funding is always a challenge, but I think working together, we should try and ensure that we keep this going, because it's such a wonderfully worthwhile program of research, which importantly stretches right across our multi-professional workforce. So with that, I shall hand back to you, Stan.
Thanks, Arnie. Well, yeah, I mean, people might not know, but Arnie was right at the beginning of all of this, when it was called the London Cancer Alliance, and that was the different world, but it was the start of it. And if there's anything that characterises this, it's alliances working together. We have to recognise that London is, I don't know what, is it 20-25% of the country? I mean, it's just a huge resource, and if we can demonstrate to the rest of the country's alliances that we can work together, the other alliances could do the same, or at least we could move on that, particularly in the area of screening. You know, I think that alliances have got their own priorities, but alliances working together. The Cancer Alliance is a great invention. It does work. It wasn't invented to do research, but it can do good research, and London can demonstrate that. So I think we need to thank everybody who's helped us. I'd like to thank Anna Punn, whose last day it is with RM Partners, has put all this together. So thanks a lot. There is going to be a recording of the event, and I'm not quite sure that'll be available quite soon. Can I just ask Anna, after the meeting, for those of you who couldn't join, I'm sure that people have had to dip in and out a little bit, but there'll be a full recording of the meeting and full access to all the slides. If people would like slides of copies of slides, then perhaps best to ask Michelle, and she'll be able to do that. So with that, I think we're up to quarter to 12. I think you've done very well. Thanks very much to everybody for your participation. And if you're interested in the next call, we'll be putting that out, as I say, in the coming weeks. But before that, by all means, email RM Partners is actually Michelle, and she'll be able to direct you in the right direction, and we'll register your interest. Thanks very much.
Thank you, Stan, for all your organisational work here, and extraordinary. Thank you.
Thanks very much to Mick and to Arnie, who are really the linchpin of all of this. Thanks a lot. Bye-bye.